nice. And I hope we have here a great afternoon with a lot of information, a lot of good scientific and clinical insights. And hopefully, we're going to be together many, many more times. I also like to welcome all of you in this session. Please feel free to write your questions, and we're going to be answering them as much as we can in the end of each of the blocks that we're going to be giving. So I prepared here like 3 blocks to talk to you. I don't know if I'm going to be able to show everything because it's a lot of material and depends also on the questions you're going to have. So let's see how it goes. But feel free to ask those questions as much as you can. I like also before I get started here to thanks Beth for being here, organizing everything for me, Marco, and all the sponsors, Nobel Biocare, Dental Corp, High Tech, and everybody essentially that is part of that. So thank you guys, and let's do the best of it. So without further ado as well, I like to share my screen. Can you see my screen? Not yet. Now can you see my screen?
Perfect.
Okay. So let me get started here. So that is it. So the first part of my lecture is going to be devoted to this very interesting topic, which is fresh socket management. And I'm going to be providing you a decision tree that we use. So ImplantePerio is decision tree driven. And many of those decision trees that I'm going to be talking about here and live when I'm going to be there with you, those decision trees were prepared by us. So it's our own interpretation of the literature and according to what we understand in terms of the clinical practice. Okay, so I hope you enjoy it. And I would like to say that nothing that you're going to see here is my personal work. Though this is like a collaboration of 3 brothers, brothers in arms, as we like to say. Okay, so myself, Jolie, and Paulo, we've been working together for 20 plus years. And during this time, we have had the opportunity to, as I mentioned, interpret the literature and interpret our own outcomes in terms of the procedures that we do. And out of that, we were able to create our own decision trees to better treat our patients, that eventually those decision trees became the book, as Michael said. And during these 20 plus years, some things changed, some things didn't change. So as you can see here, we grew up a little bit. So now we have more people involved in our institute. But the thing that did not change is the fact that we're still working together, very, very hardly together. And our enthusiasm for our profession only grows. So our commitment to do what we do is pretty much untouched, and that is the backbone of our work, working together in collaboration, always trying to improve the things we can do. And getting started, this is the final outcome of 3 cases. Maybe those cases are not perfect. As you can see here, some problems here and there in terms of the color of the teeth, the architecture of the soft tissues, but pretty much I would say that those outcomes are very, to say the least, reasonable. They are not so bad at all. And one wonder, what is the difference here between or among us, those 3 cases? So the difference on among us, those 3 cases, is how they started. Okay, that's the difference. And of course, we have to understand where is the implant there, or where are the implants in cases like that. So some lines can be drawn in terms of the height of the gingival margin, the height of the papillas, and that would indicate for some of you where the implants are positioned. But overall, I can say that the outcomes are good. But again, what's the difference between or among us those cases? And the difference is where we started. So as you can see in the lower pictures, on top of those other pictures there, we can see how we started and how we finished those three cases. And as I mentioned to you, the outcome is not perfect, but I would say they are very good if you consider how we started the clinical cases. So on your left, you can appreciate here that we had like a failing tooth that we managed to take out and perform the so-called fresh socket management, which is the topic of the first part of my lecture here today. In the middle, we got the patient already with the missing tooth in a way that we had already the collapse of the bone and the soft tissues because of that tooth loss. And now we have to deal with that deficit in the volume of the bone and the soft tissues, and eventually being able to reconstruct the area to achieve an outcome like that. And very oftentimes, we have patients that comes to the office with a malpositioned implant or with an implant with a, a implant supported restoration with some cosmetic problems or sometimes biological problems. And from that situation, we have to think about what are we going to do with this implant? Can we keep it? Should we extract it and start over again? And eventually being able to finish the case, such as this situation here. And as a matter of fact, I'll be talking about that too on the second part of my presentation. So that is the difference. But what's the similarity of those cases? So what they convert, what is the convergence of those three cases? And they convert the way we treat and address those cases. So here you can appreciate the so-called the three pillars of the static periodontology that we coined, that we created, which is published here in our book, as Michael said, our Bible. And for us, it is because we put a lot of effort to write that book. So if you want to have like a very comprehensive understanding of this perio-implantology world, not only around teeth, but also around implants, you can have in this book here. And those pillars are essentially related to the three-dimensional implant position, to the static tissue reconstruction, meaning that we have to rebuild the bone and the soft tissues around the neck of our implants. And for sure, an excellent prosthetic management. So if you becomes very efficient in those three parts, very oftentimes you're going to have a great final outcome related to that, as I just showed you in those three cases that although they have started in a very bad situation, we are able to treat those cases according to those pillars, using different strategies, different technologies, different techniques, but always related to this kind of mentality, related to the pillars of the static periimplantology, and being able to finish the cases the best that we can do, perform according to the initial situation of our patients. On the same line of understanding, and this is, my dear friends, a very important part of our philosophical approach in the beginning of my lecture here. So you can see here two young ladies with a high smile line, as you can see here, with a gingival recession in one central incisor. And in the X-ray, you can see that the interproximal bone here is preserved. And we can see that there is a good amount of keratinized tissue around the neck of those recessions. So that essentially is a class 1 Miller recession or recession type 1, according to another author called Cairo. So anyways, those two clinical situations, which is essentially related to the gingival recession, affects in great deal the aesthetics of our patients. And how we treat a gingival recession class 1 in the anterior maxilla. We treat that using the coronal advanced flap or the modified envelope that we created or we re-edited, as I'm going to show you, in association with a connective tissue graft, in which the soft tissue will be brought in the coronal direction, covering not only the recession, but also the connective tissue in a way that we don't have any color change in that area. And after some time, this is it. So 5 years down the line, 5 years down the line, we have here a complete root coverage without any problem in those situations. But there's a catch here, my dear friends. And the catch is that the outcome is the same, but the initial clinical condition is very different. Because on your left, this is a pristine tooth. Nothing is happening here. So only a tooth with a gingival recession. But here on your right, this central incisor here is broken at the level of the crown to the root. So we did this procedure here, which is the soft tissue part, in association with the removal of the tooth, the immediate implant placement, the static tissue reconstruction, meaning the bone filling the gap, and the soft tissue part, which is the connective tissue graft that was placed underneath that pouch that we created. And out of that, after some years, we can see here that not only we have the aesthetics of the case solved, but now associated with a very nice, I'm sorry, very nice implant supported restoration with a good bone, with a good implant position, and everything seems to be very good. So we have coined here the term perio-implantology, which essentially means that I'm sorry, I had the flu, so my voice is not good today. I'll be coughing all the time and drinking water to hydrate here my throat. I'm sorry for that. But we just saw here is the combination of the perio concepts to the implant procedures. And that we coined the term perio-implantology. So in the early 2000s, we were one of the first groups to really bring that concept together. So soft tissue management in association to implant to improve our aesthetics and the longevity of our outcomes. And both cases that we just saw here were done according to this modified envelope technique that we published in 2015 in our book. And this is a modified technique, or modified envelope technique, because we changed the way we prepare the site and the way we suture the connective tissue graft that is positioned underneath that pouch. So originally, this envelope would be performed using a partial thickness approach. So using a 15C blade or a microblade, we would go intraocularly here and dissect in a partial dissection way, all the way apical to the mucogingival line. And then, of course, the connective tissue would be positioned. And in the original technique, they also did not bring the flap in the coronal direction. So pretty much leaving exposed that connective tissue here. In our modification, we start always with a full thickness flap approach. So we don't use the microblade here to start. Maybe we can start with the microblade, but always we're going to use a tunneling instrument that will be connected to the interface of the bone and the soft tissues, pretty much elevating the periosteum and the flap together in a way that the maximum of the volume of the flap will be elevated here in this area related to the keratinized tissue. After we pass the mucogingival line, then we can do the partial dissection with the microblade to bring the tissue in the coronal direction without any tension. And after we place the connective tissue here and suture interproximally in the base of the two adjacent papilla, then the modification that we suggested is to bring the tissue coronally using sling sutures or anchoring sutures around the contact point in a way that all the tissue is going to be covered. All the connective tissue graft is going to be completely covered, providing a better aesthetics to the case because now we don't have any color change, no scars to the interface of the graft and the original position of the gingival margin. And of course, we maximize the vascularization to nourish the connective tissue that's going to be positioned underneath that pouch. And so therefore, we like to use very much this modified envelope. And most of the cases that we do, we use this modified technique to deal with the soft tissue part. Here you can appreciate the same kind of problem, but on a tooth versus on an implant. So here, this is a recession around this canine, and this is the recession around the implant supporter restoration here in the central incisor. And as I mentioned to you, whenever we have this kind of problem, which is the gingival recession, regardless if it's a tooth or implant supported restoration, we're going to be using the modified envelope technique. And they differ a little bit on the site preparation. So when I'm treating a tooth, I'm always going to be using this tunneling instrument, always starting from the base of the papilla and then moving to the center and going beyond the mucogingival line. But here, when I'm talking about an implant, I'm going to start always also in the base, but essentially in the center of the area where is the implant is, generally we go with a microblade because very oftentimes we don't have the bone covering the implant itself. So if you try to do a full thickness flap in that area, that can be very difficult and you can actually perforate the flap. So after you create that mobility by passing beyond the mucogingival line, then this is the moment to get our connective tissue graft and position it, in the area that we want, which is cervical to the CEJ or the future gingival margin here, or the future gingival restoration margin in that area. And then we stretch the connective tissue, stabilize it on the base of the papilla, and here you can see on both sides, we performing the sling suture or anchoring suture around the contact points, bringing the tissue in the coronal direction. Please observe that by doing this approach, which is very unique of our group, we have always this distortion here of the mucogingival line, which is a drawback in this situation. It's much more challenging when we compare this with the traditional trapezoidal flap that also produces some scars and maybe sometimes produces the loss of the tip of the papilla. So the advantage of this technique here, on top of those difficulties that I just mentioned to you, is the fact that we don't touch the papilla. And by not touching the papilla adjacent to the recessions, we may not have the loss of that papilla. And that is a great advantage to those cases. And leaving that situation like that, we can get to an outcome like this. So both cases with complete resolution of the gingival recession on a tooth or on implant-supported restoration. So the message here, my dear friends, is that regardless of the substrate, it can be a tooth or an implant, the technique that we're going to be using to improve the quality of the soft tissues is exactly the same, regardless implant versus teeth. And that is the essence, the backbone, the DNA of ImplantePerio philosophical approach, and that is why we call it perio implantology. Okay? And success in implant dentistry pretty much is this. So this guy here has an implant in his mouth, and it's absolutely impossible to any place on planet, any person in planet Earth to say that this guy here has an implant supported restoration, because everything here is perfect in every single sense, not only on the crown, but also related with the soft tissues. And that can only be accomplished if we are faithful to the pillars of the perio-implantology. So, implant well positioned, three-dimensionally, the static tissue reconstruction, meaning the bone and the soft tissue, to provide this bulkiness around the neck of our restoration, and a perfect prosthetic management. So if you do that, you're going to have an invisibility of your case, meaning that nobody can tell. The outcome is going to be very natural, and it's going to be stable through time. So that is so important to understand soft tissue management, which again is the basis of our work. We only became successful in the business of implants because we are good already in dealing with soft tissues around teeth. And that knowledge was brought to the implant service in a way that now we have this kind of opportunities. And by the way, this is how we started. So this is how the case was presented for us with this altered passive eruption, with this discolored teeth, and the center incisor with resorption here, root resorption. So we removed the tooth, we placed the implant, we did the static tissue reconstruction, we did the good prosthetic management, and down the line here, several years, we have a beautiful case that is maintaining through time because of the pillars of the static perio implantology. And if you fail in observing those principles, you're going to have the creation of some static and biological problems. So maybe you can all recognize a case like this in your office. So this is, unfortunately, this is so common to get to the office today, in a way that all the times you are seeing patients with these problems, and that is related to the not observation of one of those pillars that I just described, and maybe sometimes multiple problems related to that. So we have to learn how to prevent these problems by knowing how to do well the procedure, so following the pillars of the static perimplantology. But unfortunately, those cases, they pop up in the office very often, as I just mentioned, and we must learn how to deal with those problems. And this is, again, just after the first block, I'll be tackling into this situation here, how we should treat cases like that. So after this kind of introduction, and the main part of that introduction is understanding the concept of perimplantology. So after that, now we go in depth as much as you can on the first part of the presentation, which is fresh socket management, meaning that a patient comes to your office with a failing tooth, and you have to take out the tooth, and from that moment, you have to decide what to do. So pretty much everything should start with a minimally traumatic extraction. So it doesn't matter how long you take a tooth out, how much time you use to take a tooth out. It doesn't matter what kind of instrument you have. But what is essential here is that after the extraction, you have an absolutely nice soft tissue architecture preservation, and there's as much bone possible to be preserved as well. So we do that in a flapless way. So we don't elevate flaps in most of our cases. Some cases we do have to elevate flaps, but the majority of the cases we don't elevate flaps, okay? And we use delicate instruments. So if the crown is connected to the root, okay, I can use a forceps and do rotational movements to bring the tooth out. But if the crown is not connected to the root, to avoid damaging the surrounding tissues, we like to use those vertical devices. So there are several on the market to remove the bone, the tooth in a vertical direction, pretty much like removing a cork from the bottle of wine. So bringing that in the vertical direction, minimizing the trauma here around the neck of our, tissue margins. Sometimes we can use the burrs to cut the teeth, when it's very hard to remove. But most of the times we do that in the mesial direction, mesial distal direction, and that we do when we are doing the socket shield concept. So unfortunately, today is going to be very difficult for me to talk about that, but some cases we preserve a little bit of the root of the tooth to prevent the resorption of the buccal bone. And that is something that we're going to be talking in a moment. But regardless of the technique and the time to take a tooth out, what is important is to have something like that. And that is a very nice soft tissue and bone architecture preserved. And after you take the tooth out and you debride the socket to clean all the granulation tissue, now this is the moment to take your decision. What comes next? So what do you do when you take a tooth out, specifically in the anterior zone? What are the options that we have? And we know from the literature that we can do nothing. We can just suture, which is unfortunately what many people still do in their offices. And this is very bad to be done in our understanding, in our philosophical approach, but it's an option to do nothing, suture, waiting some months, and then dealing with the resorption of the bone, sometimes having to do bone augmentation, sometimes having to perform other kind of treatments, but essentially doing the so-called late approach. Sometimes we can take the tooth out, wait like 6 to 8 weeks, and do the early implant placement that is very much used by the ITI group, for instance, which we think it's a very bad alternative in our understanding. And we can do something related to the socket preservation using graft materials inside the socket to wait some months until that the bone graft is incorporated into the socket, becoming a nice healed ridge, in a way that in some months we can come back and place the implant with a very nice volume of bone in that situation. But sometimes we can do the immediate implant placement, meaning that we're going to take the advantage of the extraction surgery to also place the implant directly into the fresh socket. Okay? So we can do many things. And for sure, the literature overall suggests that's nothing right or wrong here. It's a matter of interpretation. And every one of those alternatives here, they have their specific list of advantages and disadvantages. And you, as a clinician, has to understand those considerations to define what's best for your patient. Okay? And I'm going to position myself to show you what we do in our practice when I have the opportunity to take the tooth out. But before that, it's important that you understand that whenever you take a tooth out, you're going to have some resorption of the socket. And we know that for many publications, and this is only one of the several publications by my very good friend, Dr. Mauricio Araújo from Brazil, that works very in collaboration with Professor Lindy, that they showed histologically the events that take place after you take a tooth out. So essentially, we have a clot formation inside the socket. You can see here the lingual bone, the buccal bone, and the soft tissue covering the socket, and the clot being formed here inside. Then, after some time, that clot will become the granulation tissue that will be invaded by the cells coming from the bone, okay, the marrow bone, and then we're going to have the formation of the provisional matrix. This provisional matrix, which is like a more organized tissue, gives birth to the woven bone that through time will completely fill the socket. But here you can see that the woven bone here is very unstructured. It's not a structured bone. So that is not allowed to have any load of implantment because of that. Okay? And also, you can appreciate that during the formation of the bone, of the woven bone, which is the immature bone, there's almost no change in the architecture of our socket. Very important to observe. This process of creating this immature bone inside the socket is called modeling. Modeling is the formation of the immature bone. And here, when the immature bone is mature, so lamellar bone, this is called remodeling. So remodeling is the change from immature to mature bone. And please observe that during this maturation of the bone, now this is the moment where you lose the height and the volume of the ridge, specifically here in the cervical buccal area, which is the most critical area for us. So first information, if you take out the tooth, you're going to lose the volume. That is the first information. The second information, my dear friend, is that if you place an implant, immediate implant, in the socket just after the tooth extraction, that will not prevent the resorption of the buccal bone to take place. So again, my very good friend, Dr. Mauricio Araújo and Lindy and many other papers also address the same way. They could see that regardless of placing an implant or not, the pattern of the healing of the bone is exactly the same. So the immediate implant placement do not prevent the resorption to take place. And the question is, why that happens? Why that happens, my dear friend? And that happens specifically here on the cervical region, because in this area, the bone is very thin. And internally here, it's all related to the so-called bundle bone. So the bundle bone is this internal line of the bone that belongs to the periodontal ligament. So whenever the tooth is out, this bundle bone that you can see in the x-ray, like the lamina dura, in the periapical x-rays, we see that very whitish part of the bone called lamina dura. Histologically, that is the bundle bone. That goes away after we take a tooth out because there's no tooth there anymore. There's no periodontal ligament. Therefore, that area resorbs. And the dimension of this bundle bone is like 0.4 millimeters. And we know that the buccal bone in the cervical area is almost all comprised by this bundle bone. Therefore, because it's so thin, when we take a tooth out, that bone, regardless of what you do, is going to be lost, through time. The next question is, how thick is the buccal bone, my dear friends? So many publications were done trying to address this topic. And these are only 2 publications showing exactly the same, showing that in the majority of our patients, like 85% of our patients, the average thickness of the buccal bone in the cervical area is less than 1 millimeter. Remember that the thickness of the bundle bone is 0.4, 0.5 millimeters. Therefore, the majority of that structure is made of the bundle bone. So the majority of our patients has the bone thinner than 1 millimeter. The average number of that thickness is 0.6 millimeters. So again, almost all comprised by the bundle bone. And many patients, like 50% of our patients, the thickness of the buccal bone is less than 0.5 millimeters. So again, this is a very thin bone that in most of the patients, you're going to lose that height. So second information, because the buccal bone in the cervical area is so thin, it's going to be resorbed regardless of what you do. Okay? And just to finish this mindset part here of the lecture, those guys, Dr. Viviana Chapuis, Mauricio Araújo, and Daniel Boozer, they did a very interesting publication. So they got patients that failing teeth in the anterior zone, but with the buccal bone preserved, okay? And they took the tooth out, and then they did the CBCTs. And here in this area here, you can see a very thin buccal bone. Remember that the majority of the patients will fall in this kind of classification here, very thin bone. But in some patients, like 15% of the patients, they had a thicker buccal bone, like more than 1 millimeter. And then they took the tooth out, they did the CBCTs and categorized it in thin versus thick buccal bone. Then they waited 2 months. So after 2 months, they repeated the CBCTs. And please observe what happened here. So when the buccal bone was thin, and by the way, that represents the majority of your patients that sits in your chairs, okay? Because the majority of the patient has very thin buccal bone. Please observe that there's absolutely in the human being, in our patients, because what you saw histologically in the dogs, may not replicate exactly what happens in the humans in terms of the timeline. The biological process is the same, but the speed is completely different. So in 2 months, in the human beings, your patients, because you're not a vet, you are a dentist treating human patients. After 2 months, the buccal bone was completely gone, or 70% of that gone. But there was absolutely no bone formation inside the socket in those patients with a very thin buccal bone. But in the patients that represent like 15% of your patients, in which the buccal bone is thick, please observe that after 2 months, there is no bone formation inside the socket because there's no time for the bone formation in the human being like that. And there is only a minor loss of the height of that area. Because here again, the buccal bone is thicker. And then we have the cortical layer outside, and then internally, the bundle bone that will resorb. And because of that, we lose the height like 0 point something millimeters in that area. Okay, so having that in mind, if you don't understand this biological process and don't take that into consideration at the timing of implant placement, or that when you take a tooth out, you may have your static nightmare. So we have to understand that regardless of what you do, if you take the tooth out, okay, you're gonna have the resorption of the bone. And you have to understand that concept, because by losing the height of the bone, you may also expose the threads of your implants, leading to biological and aesthetic complications. So we have to take that into consideration. Having said that, my dear friends, having said that, so this is it. I take the tooth out. This is the fresh socket. And now I have to make my decision. I told you that those are the alternatives, but I named to you that in our understanding, it's not so smart to take a tooth out and doing nothing about it. Because the more we wait, the more resorption we're going to have. And if you wait only a couple of months, maybe you can place the implant. But now you have to do simultaneous reconstruction, meaning placing the implant and some bone graft in that area. But to do that, now I have to open a big flap to expose the area and being able to reconstruct that area in the best way possible. And if you wait a little bit more, you can have so much bone loss that now you have to do a GBR. You have to do like a bone grafting procedure, which everybody knows it's very demanding clinically and biologically, and very traumatic for your patients. Very hard to be done, to be replicated. As opposed to that, why not taking the advantage of the tooth extraction and doing some reconstruction to prevent the volume deficit that is going to happen? And that can be done placing a bone graft inside the socket itself, or you can place the implant and the biomaterial in that moment. So here I'm going to present you in a couple of minutes the decision tree. When to do what? When are the cases that I do immediate implant placement? When are the cases that I do socket preservation? Okay? And when I'm doing, when I'm working inside the socket, that is called internal socket compensation. But when I wait and do not do anything at the time of the extraction, now I have to do some reconstruction outside the boundaries of the socket, which is now resorbed because I didn't do anything. So that is external compensation. And it's much more challenging to do external socket compensation as opposed to internal socket compensation. So the question is, my dear friends, why to reconstruct what you will lose if I can preserve what is still there? Therefore, now it comes the moment to decide what to do, because in my opinion, it's not a good idea to take a tooth out and do nothing I just mentioned to you. So in my office, in majority of the cases, I'm going to do either the immediate placement as my first choice, or I'm going to do the socket preservation if I can't do the immediate implant placement. But this is not a random decision. This is a decision made on the observation of some parameters. And by the way, has been published in some publications of our group and our book as well. But anyways, those are the aspects that you should be considering to perform one thing or another. And namely, the two most important are the amount of bone that is apical and palatal to engage our implant. So how much bone is still there to engage our implant? Okay, I'm not talking about the buccal bone. I'm talking about the apical and palatal bone to insert my implant. And the position of the gingival margin of the tooth to be extracted. So those two are the most important to define the path of the treatment, immediate implant placement or socket preservation. However, we still have to observe how is the buccal bone, if it's present or it's damaged. So how is the buccal bone and how thin or how thick is the soft tissue? Okay? So as I mentioned to you, those two here are the most important and they will define the path of the treatment. So making this very long conversation short, this is it. I have to see the CBCT of my patient to check the anatomy of the residual bone, and I have to observe the position of the gingival margin. And basically here, when you consider the CBCT, there you have the bone or you don't have the bone to place your implant. So there's a classification here, class 1 to 4 by Joseph Ken, but I'm going to skip that. So please observe, do I have the bone to place the implant or not? That's the question. And the other thing is, where is the gingival margin of the tooth to be extracted? And here you can appreciate that I can have sometimes the gingival margin of the tooth to be extracted to be a little bit more coronal to the adjacent tooth, which is my reference here. It can be leveled to the adjacent tooth, or I can have a gingival recession. But a gingival recession can be like small or big. So let me name a small gingival recession of the tooth to be extracted up to 4 millimeters, no more than 4 millimeters. Or it's going to be deep beyond 5 millimeters recession. So those two informations are very important. So if the palatal and apical bone is present when you look the CBCT, and at the same moment, the gingival margin of the tooth to be extracted is coronal, leveled, or only a couple of millimeters apical to my reference point. So if I have this scenario here, I'm going to move for the immediate implant placement, regardless of those two guys here, the buccal bone or the tissue phenotype. I know that the discussion of the buccal bone is very hot, but for maybe 15 years back, we understood that the buccal bone is going to be resorbed anyway. Sometimes it's not even there if you consider why the tooth is being extracted. And we have to compensate that by the things I'm going to be teaching you in a moment. Okay? But so, therefore, if I have the bone and I have a good soft tissue position, I'm going to move for the immediate implant placement. On the other hand, if I don't have the apical and palatal bone, it's so thin or it's not reliable to engage my implant, or the gingival margin is very apically positioned. So please observe that when it's time for the immediate implant placement, I said having bone and a good position of the gingival margin. But here, when it comes to the socket preservation, the word now is or. I mean, I don't have the apical and palatal bone, or I have a deep gingival recession. In those situations, I'm going to be moving for the socket preservation. Simple as that can be. Professor Robert, I don't agree with you. It's fine. The literature shows that you can do whatever you want. All options are valid. But this is how we think, and this is how we've been treating our patients for more than 15 years now. What about the buccal bone? And this is a very hot discussion. And here, trying to summarize things, I can have this situation that the buccal bone is preserved. There is absolutely no buccal bone loss. I can have this apical defect that we call fenestrations, or we can have these cervical lesions that are called dehiscencies. And the dehiscencies can be classified in narrow or wide, shallow or deep. So a narrow dehiscence is that when the mesial distal aspect of this buccal loss in the cervical region is less than 1/3 of the mesial distal dimension of the socket. But if it's more than 1/3 of the mesial distal aspect of the socket, now we call that a wide dehiscence. A short dehiscence is based on the vertical component here. And if I have like 4 or 5 millimeters of bone loss, then it's shallow. But if it's beyond 5 millimeters, then it's deep. Okay, and then you can understand you have these kind of possibilities. Okay, narrow and deep, narrow and short, and stuff like that. So there is a multitude of different situations that we have in our office here. And remember that depending on the reason why the tooth is being extracted, so fracture, endo, perio, resorption, whatever, okay, many times the buccal bone is not going to be there anyway because of the pathology involved with the reason why that tooth is extracted. So remember that in many cases, you don't have the buccal bone there anymore. And even if it's there, in the majority of the cases, the buccal bone thickness is going to be very limited and it will be resorbed because of the discussion we did before. And I pretty much know that many people in the globe, I don't know about Canada, but this phrase here was very, very important some years ago and still is for a lot of people. And they claim that if you don't have the buccal bone, you shouldn't do the implant. So I respect that. I have no conflict with that, but I completely disagree with that. So I mentioned to you that the buccal bone is going to be resorbed anyway, most of the cases. And we never place the implant very close to the buccal bone. So we always place the implant palatally and apically. So we have this so-called green triangle, which is the osseointegration area, which is apical and palatal to the socket itself. So regardless of the buccal bone, we should be able to place the implant here if we have this availability of bone. But here in the red triangle, which is the aesthetics or the biological part of our implant support and restoration, regardless if the buccal bone is there or not, if I have the space, I can reconstruct that area in a very good way. And we know that this reconstruction is possible. Many publications would show that you can regrow the bone there histologically, observations, CBCTs, everything showing that it's possible to reconstruct the area. So the thing is what to do regarding this bone defect. So let me be very straightforward with you, my dear friends. So if you have something like this, which is this whitish box here, in which there is no buccal bone problem, if there is a fenestration apical, or if I have some kind of dehiscence that is not wide and deep at the same moment. So meaning that I have lost all the buccal bone. If I have something that is not like this, regardless if I'm doing immediate plug placement or the socket preservation, we're going to fill the space with a bone graft. And we like to use the xenograft, specifically the xenograft with the collagen incorporated to that because it's way, way easier to be done. So if I have something like that, in the area of the gap in the immediate plug placement or the socket itself, we're going to always use this biomaterial in a way that this biomaterial prevents the collapse of the bone because this is a material that will not resorb. It favors the growth of the bone around the particles, but it doesn't really allow the resorption of that area in a great deal. So that preserves the volume of that area. But if I have something like that, in which it's completely missing the buccal bone wall, so there is a wide and deep fenestration at the same moment, what should we be doing? I mean, we're going to still use the same kind of biomaterial, but now, regardless if it's immediate implant placement or socket preservation, we're going to use a collagen membrane, pretty much protecting the bone graft that is inside, positioned inside the socket, and in between the soft tissues with the flap and the boundaries of the bone, because the buccal bone is lost, we're going to be positioning our membrane there in a way that it will protect the contact of the cells of the soft tissues and the bone particles that are within. So pretty much that is it. In all cases, I'm going to use my biomaterial, and when I have the completely missing buccal wall, I'm going to be using a collagen membrane, regardless if I'm doing a mid-implant placement or the socket preservation. What about the tissue phenotype? So, through time, my dear friends, we changed our mind about this topic. But in the past, we would do something. But today, we're going to do another thing. I'm going to be telling you that in one moment. But before that, please observe those two CBCTs, completely missing teeth, missing bone, and the tooth is completely hopeless. But please observe the soft tissue architecture in those two situations. Here, although there is no bone here, there is a big gingival recession. Here, although the tomographic aspect is very similar to the one observed on the upper jaw on the other image, you can appreciate that there is absolutely no gingival recession take place here. So in the past, my dear friends, when I had something that is not like this, very thick soft tissue, I would be doing always the connective tissue graft to further improve and increase the dimensions of the soft tissues. So in the past, when I had anything not like this, which is very thick soft tissue, I would be doing the connective tissue graft. Today, I'm going to be using a connective tissue graft in every single case, even if I have a very thick soft tissue like this in the beginning, and I'll be demonstrating that to you in a moment when it comes to the clinical cases. So pretty much that is what I wanted to show you as a decision tree to understand how we deal with all those clinical scenarios. Okay, so using the membrane or not, related to the presence or not of the buccal bone. Okay, we're going to be always using the same kind of material, which is the xenograft, inside the socket if I'm doing a socket preservation, or inside the gap if I'm doing immediate implant placement. And I'm going to be using always the connective tissue graft using that modified envelope technique that I described to you in the beginning to increase the volume of the soft tissues. And as I mentioned to you, you can find evidence for whatever you want in the literature. So the literature will support you in almost everything you want to do, but there is no consensus for any of those things. So you have to understand the philosophies that are available to you, they are presented to you, and have to pick one to be treating your patient. And this is what I wanted to show you in terms of my philosophical approach. Having said that, now it's the moment to come to the clinical cases to see or to challenge the concepts that I just suggested to you in the clinical reality. And this is the first patient that I wanted to show you, a very young patient that has a high smile line, as you can see here, and she has this canine that is apically positioned, and you can see there is ankylotic and there is a resorption here. As a matter of fact, this tooth here was, inside the bone horizontally like that. So somebody took it out and reimplanted it in the right position. But unfortunately, it developed here, this ankylosis and this resorption. Please also observe that this patient has some interproximal problem, which is always very demanding to be solved. Okay? This muscle pull is here because of the surgery the guy did. But anyways, now you have to make a decision. I think everybody understands and agrees with me that this tooth is hopeless. So what to do after we take the tooth out? Okay, so we took the tooth out. In this case, it was a very difficult extraction because it was ankylotic. So we have to use the piezo, we have to use the burrs, and it was very difficult for us to remove the tooth. But anyways, after the tooth was removed, you can see that we still have here the integrity of the gingival margin. But unfortunately, you can see here that the position of the gingival margin of that tooth that was extracted is very apical in relation to the adjacent area. But we have the apical and palatal bone, but we don't have the soft tissue. Therefore, my dear friends, we didn't feel comfortable to place the implant here in this area because not of the bone, because here in the bone, I can place my implant here. But the problem is that I don't have the height and the quality of the soft tissues. Therefore, I'm going to do the socket preservation. And this socket preservation is called the biocol, meaning that we use biomaterials to do that. So inside the socket, you can see that we filled the socket with the xenograft, which is the material of choice for us. But you can appreciate here that in this case we have added the collagen membrane. Why we have added the membrane here, my dear friends? That is because we didn't have the buccal bone. So if the buccal bone is not there, I have to place my membrane there to prevent the soft tissue to grow inside the bone and prevent the bone formation, okay? To create a fibrosis there. Therefore, I have to create a pouch, which is the modified envelope, and I'm going to place this collagen membrane underneath in a way to protect my bone graft. And because I have a gingival recession, I have to boost the soft tissue. And here you can observe that we are performing this rotational pedicle flap of the connective tissue. So this is like a rotational of the connective tissue, keeping the vascularity here preserved in a way that will preserve the vitality of that soft tissue. Okay? Now, we have to close the socket with the membrane, okay, like this, protecting him not only on the buccal, but also on the occlusal aspect. And then we rotate on top of that our pedicle of connective tissue, keeping the vascularity here. Robert, this is easy to be done? No, it's not easy. But you have to practice. You have to learn the skills to do it as a technique to prevent you from doing a big GBR later on. Because if I haven't done anything here, probably I would have a big bone defect, and then I'll have to do a external bone reconstruction, which is very demanding. Here I'm working inside the socket. So inside the socket, the biomaterial, on the buccal and occlusal, the membrane, and occlusal and the buccal, the connective tissue graft. And then, of course, we suture everything the best way we can. And this is our patient after 6 months. You can appreciate that after maybe 4 months, we did here like a bridectomy. So we took out those muscle pull, and now you can see there is no, muscle pull attached to the area. You can also see that where was a very big recession, there's absolutely no recession anymore. And you can see that where there was no keratinized tissue, there is a good amount of keratinized tissue here in this area. So, my dear friends, we are able to reconstruct the soft tissues in great deal, vertically, height, and quality. Of course, that we have to evaluate the bone. Underneath that, In that given case, for specifically, it's a very old case, so we didn't have the CBCT at that moment. So we anesthetized the patient, having only this X-ray, and we probed from the buccal, from the occlusal, and from the palatal area to check if the bone was there. So we liked what we could see, would understand in terms of that soft tissue probing, and then we felt that the bone was there. Therefore, we did a circular incision here, like a punch, and we placed our implant here in this area. Please observe the volume of the soft tissue here. Please observe the quality of the soft tissue here. So an implant was positioned. After the osseointegration phase, so our colleague from the prosthodontic here, Dr. Bruno Godoy from Brazil, he created for the patient this custom healing abutment that was adapted on top of our implant, okay? And then the final restoration was delivered for the patient, and some veneers were also placed here and there to improve the overall area. We also did a small crown lengthening here on adjacent teeth, trying to increase the area. This patient here is a professional dancer, so she travels the world in a company, specific at that time. So that's why she wanted to do something like finished, and she didn't know when she would be returning to Brazil again. That is why my good friend Dr. Bruno here, he made though that restoration with the preservation of this space here that now seems to be a black triangle. But we have to be faithful in terms of the quality of the soft tissue, and this space can be filled with soft tissue through time, and we have to believe that, but in accordance with the good quality of the soft tissue. And 1 year later, the patient came back, okay, and you can see that the papilla filled in the spaces, and now you have a beautiful, reconstruction in that area. So now maybe it's not perfect, but it's much better than we started in the initial aspect of that situation. All right? And you can see here the CBCT of the case, showing the implant well positioned and a good amount of bone buccal to that area, the papilla filling the space, good keratinized tissue on top of the cervical of that restoration. Robert, what happens through time? And this is what happens through time. So 12 years later, the patient returned to Brazil, and we're able to see that patient, and you can appreciate right now, after 12 years, how the patient looks like. You can see that clinically, the soft tissue is even better than 1 year. Because soft tissue, my dear friends, is like wine. It's improved through time. So whenever you place a connective tissue in those areas, through time, you're going to see a further improve and increase in the volume and the quality of the area, most of the times. You can appreciate here there is absolutely no loss interproximally, and the buccal bone is completely preserved in a very, very good way. So it works, and works very well. So here you can see how the patient started, 1 year and 12 years down the line. Very nice resolution. Another clinical situation also on a canine that we addressed exactly the same way. So this is a failing canine because of this perforation here that happened here in the mesial aspect of that tooth, and there is a recession here in this area. Not a big recession, but an important recession here. But when you observe the bone, you can appreciate that there's absolutely no apical and palatal bone to place my implant here, because this is the nasal cavity of the patient here. Okay, so there's no bone. If you want to place the implant here, it has to go inside the nose, and we don't like doing that, right? So there's no indication here to do immediate implant placement, but we can do exactly what I just mentioned to you, to take the tooth out in a minimally invasive way without elevating the flap, We remove all the granulation tissue, and now we create a pouch. So full thickness in the area of keratinized tissue, and beyond the mucogingival line, we perform the sharp dissection. And then we do exactly the same as in the other case. Because the buccal bone is not present, we added the membrane. We always use the biomaterial, which is the same for us. This is a xenograft, specifically with the one with the collagen. And then we have to close the membrane occlusally to protect the bone graft. And then we rotate it again, the pedicle of the connective tissue, in a way that we are able to further increase the volume of that area, okay, and recreate the nice conditions of the soft tissue here around this area. Please observe that we didn't touch the papilla. The provisional restoration was adhesively positioned, as you can see here, so adhesive prosthesis, and then we used that suture around the contact point to bring the tissue in the coronal direction around the cervical region of our provisional restoration. And then we have to wait. So after 6 months, you can see the soft tissues unbelievably good. So a perfect integration here of maintenance of the papilla. There was a recession, now there is no recession, and we have a good amount of keratinized tissue here. However, when you look at the CBCT, there was a problem here. So we have made a mistake probably here in terms of the condensation of the biomaterials. So here you cannot see the integration of this part of the biomaterial. Therefore, as opposed to the other case where we did like a circular incision, the so-called punch technique, in this case, because we have some problem in the buccal area, we have to open a flap. So we perform an incision, a crest incision. We reflected the buccal bone, the buccal soft tissue to expose the bone. Okay, we removed that part of the bone that was loose in the buccal area, but yet we had a great amount of bone here to place our implant. So we made the site preparation, and because we have lost a little bit of that buccal bone, now we do a simultaneous reconstruction here. So we use our xenograft. We don't think it's required to place autologous bone here. If you want to add some autologous bone, it's fine, but do not miss the opportunity to use the xenograft, because that will be the volume maintainer of that area, because the autologous bone tends to resorb, but the biomaterial tends to favor the bone growth around the particles, keeping the volume in a good way. And then we covered that biomaterial, which is the xenograft, with a collagen membrane. And because we have the opportunity, why not add in another connective tissue? So again, another connective tissue here that was like a poncho technique on the Mexican, okay, that we position on top of the healing cap to stabilize the healing cap, further improving here the quality of the buccal and the proximal area because of the positioning of that connective tissue graft. Now we suture the tissue to its original position. We have to wait for sure some months until the osseointegration is achieved, and also the soft tissue and the bone is, positioned that area. It's integrated. And after some months, maybe here 4 to 6 months, now it was the moment to do the second surgery or the reopening of the site using a punch technique. And we removed the cover screw and replaced this titanium provisional abutment. And on top of that, we relined a provisional restoration, as you can see here. So this is the proper shape of the provisional restoration that would not provoke very big pressure on the soft tissues. And it was placed there. We always keep this space to allow the soft tissue to grow. I don't know if the soft tissue will grow, but I know that if I close that space with my resin, the soft tissue will not have a chance to grow in the papilla level. So we keep that embrasure open, and after some time, after some months of healing, maybe 2 or 3 months, then we can do the impression. It can be digital, or it can be like analogic, as you can see here, trying to capture all the features of the soft tissues in that kind of impression taking. And this is how the soft tissue looks like. Please observe the quality and the volume of the soft tissue here. So have a great amount of keratinized tissue. There's no scar formation, no papilla loss, no color change in that area. The perfect, texture of the soft tissue, of the soft tissue, and you can appreciate here that, the emergence profile was pretty much well because of the internal shape of that was created, the so-called critical and subcritical subgingival contours, which is so important. And now, of course, our crown is connected and it's screw, adapted to that area, and the final torque is given, and then you have the patient very, very nice. And here, 1 year follow up, but you could see the other cases with 12 years follow up in those situations. So, my dear friends, socket preservation works, and we're going to do that whenever we are not able to perform our immediate implant placement. So we have multiple cases like 10 years, 12 years, 16 years cases showing always exactly the same, which is a good maintenance of the volume of that area in a way that we are able to really, really keep the volume and place the implant in the second moment with a good aesthetic outcome. So the timing of implant placement, meaning that immediate implant placement or late implant placement, if you have performed the socket preservation, may not be the most important aspect here, because you just saw 2 cases that everything was very nice. But if you remember that the most important aspect is the static periimplantology triad, so three-dimensional implant positioning, static tissue reconstruction, bone and soft tissue, and of course, a good prosthetic management. Regardless if you're doing immediate implant placement or socket preservation, you may end up with a good final outcome. Now changing gears when I can do the immediate implant placement. So I'm going to be showing you like maybe 3 cases here that pretty much shows what I want to highlight with you. And the advantages of the immediate implant placement are several. We reduce the time of the treatment, the morbidity. We are able to preserve the soft tissue architecture and even improve that area in a great deal. So this is a case that we had the chance to show the benefits of the immediate implant placement. And my dear friends, check this lady here with this high smile line. This is like a billboard. So if you have any problem here, everybody's going to notice. So this is a very complex case. So do not underestimate the importance of a case like that when you have a high smile line. Because if you screw up here, if you do something bad or a bad decision, that can impact in great deal the aesthetics of your patient. And then you're going to be creating a big problem for you. Okay? So you have to be doing everything accordingly. So here, this central incisor is broken, but you can see that we have a perfect outline of soft tissues. We have a good amount of keratinized tissue there. And luckily, in this case, the buccal bone is preserved. It's very thin, but it's preserved. I do have the apical and palatal bone to place my implant, all right? And therefore, and the gingival margin is level to the adjacent tooth. Therefore, it is a good candidate for us to do the immediate implant placement. Remember that everything starts with a good, minimally invasive tooth extraction. So here we took the tooth out using the vertical device to remove the root without damaging the adjacent area. And then we did our site preparation here, okay? In this case, free-handed, okay? So many cases we can do that free-handed. I like to use the guided surgery very well, but many oftentimes we don't have the time to prepare the surgical guide, or the patient just showed up in the office, and now if you have the available bone, why not place in the implant directly? And we can do that. So created the osteotomy towards the palatal aspect. And this is a very nice implant. This is Nobel Active, which is a very nice, strong threaded implant, narrow diameter, platform switched. So everything that you should be looking at to have a good primary stability and biological aspect of that implant. So the implant was positioned, so we can see a good, decent position in all single aspect. And of course, because of the high primary stability here, we are able to move ahead and reline a provisional restoration on top of that. So what are the requirements to perform immediate temporization? You must have a good primary stability. The implant should be well positioned, okay, according to the prosthetic needs of the patient, and the occlusion of the patient should be observed and should allow this situation. The benefits are multiple: aesthetics, comfort, the possibility to clean the area, and most importantly, to support the soft tissues in the papilla level and the buccal aspect as well. But you have to be able to perform a good subgingival contour there. So many cases leads to gingival recession because the prosthodontist do not pay attention in the volume of that area subgingivally that produces pressure on top of the soft tissue that responds with gingival recession. So we use our biomaterial to fill the gap, in this case without the membrane because the buccal bone was preserved. And we know that whenever we do that, whenever we place our biomaterial inside the socket, because the biomaterial do not resorb, okay, it will prevent the loss of the buccal volume. So we do have the loss of that buccal bone, but because the biomaterial is dense and it not resorbs, that will maintain the pressure, that will resist the pressure on the soft tissue, will not collapse, allowing the bone to grow around the particles of that area. So please always use the biomaterial. And I see a lot of people today saying or claiming that, oh, I don't need to use the biomaterial. Okay, it's up to you. But in our opinion, I think we think you should be always considering filling the gap in a good way. Because if you don't do that and you have a collapse of that buccal bone, eventually the threads of the implants can be exposed, leading to either a static complication or a biological complication with periimplantitis. So try to avoid that from happening. And again, as I mentioned to you today, all cases we place our connective tissue graft in a way that we will be able to further increase the volume and the dimensions of that area. So increase of the soft tissues will lead to multiple benefits as well, such as reducing the risk of having gingival recession, reducing the risk of having some kind of transparency in that cervical region, and keeping the volume in long term for you. And we know today that if you have a good soft tissue thickness, that also helps to preserve the bone around the neck of your restorations. So here, this is it, the connective tissue graft inside the pouch that we created. And here you can observe the provisional restoration in place. Be careful with the restoration. Many people also underestimate this procedure and then can create contamination. So be as clean as you can to prevent anything from falling inside the regeneration area. Okay? And of course, the volume of this area is so important. The occlusion should be checked. So this is not immediate loading. We do immediate temporization. So we always check the occlusion to free these two from any premature contact in a way that it will not be used biomechanically. Okay? And this is the patient after some time. You can pretty much see that now the soft tissue is even more coronal than the gingival margin of the adjacent tooth, and that is great. We always aim to this kind of excess in the height of the soft tissues. And after some time, after some months, now is the moment to take the crown out, maybe 4 to 6 months down the line. And you can appreciate again this beautiful emergence profile, great thickness, great amount of keratinized tissue that was created because we have added the connective tissue to that area. Some particles of the biomaterial can be popping up. You just use a periodontal probe and remove it and just leave it there. The tissue will heal automatically. Of course, that in order to have that kind of situation, the quality of the connective tissue is very important. So generally speaking, the first choice for implant sites is the tuberosity because of these characteristics that it harbors here the tissue from tuberosity related to the density of the tissue and the collagen fibers, as opposed to the connective tissue graft. So here in the connective tissue graft, you can see that it's much more reddish as opposed to the tuberosity. Okay, it's much softer and it can have variable amount of fat and glandular tissue. So we prefer to use the palatal tissue for wood coverage around teeth. But whenever I'm talking about implants, we prefer to use the tissue from the tuberosity. If I take a connective tissue graft from the palate, it might be better to take a free gingival graft and to deepitalize it outside the mouth, because always underneath the epithelium, we have the so-called lamina propria, which is the best part of the connective tissue here. And you prevent getting this fat and glandular tissue that tends to resorb through time and much more difficult to place. Okay, so the free gingival graft deepitalized is a very good alternative. And we know that by adding this connective tissue graft to this area, pretty much we will increase the soft tissue stability, and the majority of the publications all agree that the connective tissue is a plus, is a positive plus in terms of the stability and the longevity of our restorations. Okay? So we took the impression, and this is the moment of the delivery of the custom healing abutment, and of course, the crown on top of that. And here you can appreciate the soft tissue architecture, almost untouched if you compare how it started. And here you can see there was inflammation here, but there's no inflammation here anymore, and a very, very nice volume of the bone here. And this is the patient after, I think, 1 year. You can see that it's impossible to say anything has happened there. This is 2 years after the implant was placed. You can see the soft tissue improving through time. So the comparison how she started after 2 years. This is 4 years, and you can see that the tissue keeps improving. Again, the connective tissue graft related areas, especially when you have a good origin of the connective tissue, good quality of the connective tissue, you're going to see this longitudinal improvement of the quality of the volume of the characteristics of that area. So the socket was intact, okay, 4 years down the line, as you can see here. And this occlusal shot is so important My dear friends, many often cases that you see in the congresses, they only show the buccal area, but they don't show you the occlusal area that shows the real picture, the real story. Because if you lose the volume here, and most of the case you're going to lose it, then even though you don't have the gingival recession, you're going to have the volume loss that dictates that really gives the clue that there is an implant supporter restoration. So it's very important to see this buckle, but not forget to do the occlusal shot. This is 7 years down the line, so everything pretty much stable. So how the patient started after 7 years, and this is the patient after 10 years, showing absolutely stable outcomes and pretty much a very, very nice maintenance of that area. So how the patient started, how the patient finished, in a very, very nice way, pretty much showing the benefits of what I just showed you. So do not forget about the connective tissue graft that not only provides aesthetics, but the longevity, and that protects the bone from resorption, as we know from many, many publications. If you place the connective tissue, you're going to have no or less recession as opposed to not using that. So why not using the connective tissue? And because of this increase of the dimensions of the soft tissue, we have these improvements in the stability of the bone as well, as I mentioned to you. Because of the time here, I'm going to jump this case, which is exactly the same as I just showed you, and I'm going to move to another clinical scenario. And this case here, my dear friends, is very important because this is one of the patients that made us change our approach in terms of the soft tissue management. So we have treated multiple cases like this one, and those cases, along with this case here, showed us that we have to address the soft tissues in a very, very specific way. But anyways, so this is a case in which you can appreciate that there is a hopeless tooth here. I think that everybody agrees that this tooth cannot be restored or kept in the mouth, okay? And no buccal bone. There's a kind of resorption here on the palatal aspect as well, okay? But we have the apical and palatal bone to place our implant. And please observe that although we don't have the buccal bone present, we have a very good amount of keratinized tissue here, and the gingival margin of this tooth is even more coronal as opposed to the adjacent tooth. So we take the tooth out. So it was a very easy extraction because the tooth was loose, but it was much more challenging to clean the socket. And it's imperative that you clean the socket. You can see that the buccal bone is lost, no buccal bone. So that means I have to place a membrane. So if the buccal bone is not there, collagen membrane. The implant was placed because there was apical and palatal bone to engage my implant, and the gingival margin of the tooth that was extracted was in this case more coronal than the adjacent tooth. So implant in with a great primary stability. So we can see here the gap. Now we fill the gap with the biomaterial, but before that, we can start preparing our restoration. So the implant had a very good primary stability. So the titanium post was placed, the provisional crown was relined, and during the polishing and the preparation of the subgingival contours, we come back to the field and we perform our um, envelope in the buccal area so that we can place the membrane. So the membrane was there, covering the boundaries of the defect. So it's important that the membrane completely covers the edges of the adjacent, socket edges, right? And we're going to use our biomaterial filling the gap. And here you can see the biomaterial inside the socket. We trimmed this excess of the membrane that was sticking out, okay? And the provisional crown was delivered. Please observe that in this case, we did not add the connective tissue graft. Why? Because, as I mentioned to you, in the past, whenever we had something that was not so thick, we would not place the connective tissue graft. And this is very thick. Therefore, in that moment in time, we felt that we didn't have to place the connective tissue in that area. Anyways, so this is the X-ray or the CBCT prior to extraction. This is the typical X-ray or CBCT just after the implant was placed, and we have this excess of bone because the buccal bone is not present, so this is excess a little bit outside the boundaries of the socket, okay? And this is the typical image after 6 months, in which after 6 months, there is time to compress the biomaterial in its original shape, which is in consideration with the interproximal bone peaks. Okay, so now you can see that the bone is formed where there was no buccal bone present. So here, 0 buccal bone. Here, more than 2 millimeters of very nice buccal bone. After 6 months, we removed the provisional restoration. You can see the beautiful volume of this area, okay? And the adjacent tooth was also prepped. And now you can appreciate the impression taken on the tooth and also on the implant site. The custom heating abutment was positioned, and you can see here that the color was completely matching the adjacent tooth. So the substrate had the same color, favoring or facilitating the lab technician to recreate 2 crowns with the same characteristics. Tooth supported versus implant supported. Exactly the same, and that's why you can see here this beautiful soft tissue and quality of the 2 crowns that were delivered. And this is the patient 4 years down the line. You can see here, this is maybe 1 year, and this is 4 years. And after 4 years, you can see the bone present, thick bone, because that stays there. And the soft tissue is quite good after 4 years. Please observe there is absolutely no gingival recession because we have a very thick bone. But if you look on the sideways here, lateral view and the occlusal view, you can start seeing that the volume is different. So if you are very picky, trying to seek for the excellence, you're going to see that this occlusal view here shows that this is an implant supporter restoration, although there is no gingival recession. And the buccal bone is very present. 7 years down the line, we still don't see any gingival recession take place, okay? But now you can already start to see that the thickness of the gingival margin of the tooth is thicker than the gingival margin around the neck of our implant supporter restoration. So after 5 to 7 years, we start to see a lot of cases with this collapse taking place. And when you see the occlusal shot, it's even more evident right now than the last picture of 4 years. Now it's obvious that it is an implant supporter restoration because we didn't add the connective tissue here, okay? So whenever you don't add the connective tissue, through time, even if you don't have the gingival recession, because we are able to recreate the buccal bone thickness here in a good buccal bone thickness, we started to see the gingival recession, the loss of the volume, pretty much determining that that site is implant related. 10 years, again, even more collapse here, although the bone is preserved. So the bone is preserved, but you see here the deficit in the volume of the soft tissue here, because the bone is in this level apical. This is the area of the abutment. And the abutment here loses, the area of the abutment is going to lose the volume because we didn't add the connective tissue this area, the collective tissue to this area, although the buccal bone here is pretty much preserved after 10 years. So we learned here a very important trick, that because we haven't added the connective tissue, we lost the volume. So today, my dear friends, in every single case in the static zone, we're going to place our connective tissue to that area. So you can see here the beginning, the after, absolutely amazing case, don't get me wrong, okay? But I know this is an implant support and restoration, and in the model line, I want to have this clinical image in a way that nobody can estimate that that is an implant support restoration. I want this to be invisible. And here I know this is an implant support restoration, although it's very nice, although the buccal bone is preserved. So the message here, the thickness of the buccal bone do not interferes in terms of the loss of the buccal soft tissue. So because the buccal bone is thick, it doesn't mean the soft tissue is going to be stable in terms of the thickness in this area. Okay? So everything good. And this is the final case prior to our break and the questions, if you have some, because this case proves the principle of the soft tissues. So here you can appreciate the central incisor, which is fractured. But you can also see that not only the central incisor of one side, but the other one also has a gingival recession. So now I have a gingival recession on both areas, in this one, this area, and also on the other area on the central incisor. So the tooth was hopeless, as I mentioned to you. There's a big pocket there, so very, very big pocket in that area. We see that the buccal bone is not present in this area, and that it happens because of the fracture. So we have a very intermediate soft tissue here, not thick tissue, but the height of the soft tissue is good. And we could see that there is a gingival recession, so on both sides, both central incisors, and I have the apical and palatal bone. So if you remember our decision tree, if I have the apical and palatal bone preserved, and if I have a gingival recession that is not more than 3 to 4 millimeters, then we can go ahead, remove the tooth, clean the area. We're checking the dimensions of the buccal bone defect, which is wide and deep, meaning that you have to place a membrane. So if you have a wide and deep defect, please use a membrane. Guided surgery, to be more precise. So one implant was positioned. So implant in, well positioned, good depth, good palatal apical position, primary good stability, very nice. Okay. Then we did our envelope technique, our modified envelope technique on the 2 central incisors, and we have added the connective tissue. So first, we're going to add the connective tissue. So in cases that I have to place the connective tissue and the membrane, we always start from the outside to inside. So first, the connective tissue underneath that area, and now I place my membrane. If I move things around and start placing the membrane, when it's time to place the connective tissue, it might be that you move the membrane from its original position. Therefore, you're gonna be losing the benefit of the membrane. Therefore, my dear friends, do outside in. Connective tissue first, now the membrane underneath. The membrane is there. Now I place my bone graft in that area. Okay? So whenever I have to place the connective tissue and the membrane, outside in. First the membrane, I'm sorry, first the connective tissue, then the membrane, then the bone graft. Here you can see the bulkiness of this area. You can see the gap that is there, filled completely with the biomaterial. And of course, the implant supported restoration was delivered, and we brought the tissue in the coronal direction. This is the CBCT after 6 months, immediately after the procedure, showing that there's a space here. So the radiologist saw, hey guys, you made a mistake. You didn't pack the biomaterial properly. That didn't call our attention at that moment. We felt that, okay, no big deal. It's going to heal in a very good way. So just a parenthesis here. So we have done multiple cases through these 20 years that we have been doing this kind of situation here. And situations like this, in which there is no bone present, we can end up with like 2.5 millimeters average thickness of the buccal bone because of this reconstruction that we do here. So always use the biomaterial. I'm going to use the membrane whenever there is no buccal bone, completely lost, and the connective tissue graft to everybody. In terms of the bone, you're going to have nothing to 2.5 millimeters. Create from zero, create 2.5 millimeters on average in that situation. Sometimes more, sometimes less, depending on several aspects. But the majority of the case, you're going to have the buccal bone preserved in a good thickness, as you can see here. And here we can see the patient back. So how the patient started 6 months later. And here you can appreciate that no gingival recession is present because we covered both teeth, and the volume of the tissue is pretty much nice. Absolutely no change in the papilla level here. And the most important aspect, please observe the occlusal shot that shows the stability of the soft tissues here. So after 6 months, this is the moment to take the provisional restoration out. You can see the thickness of the soft tissue and the quality of the soft tissues here. This is like a summary of the case. So implant well positioned, okay, and the static tissue reconstruction, meaning bone and soft tissues, and a good prosthetic management. And this is, how the patient is being treated. So some veneers adjacent to the implant to create a good aesthetics. And this is the final outcome that was achieved here. I would say a very reasonable outcome. No gingival recession anymore, papilla level unchanged, and a beautiful soft tissue profile here, as you can see here. Please observe that the interproximal bone is completely preserved here. Okay, so that's why the height of the papilla is unchanged. And always take into consideration the occlusal shot. Please observe that the volume of the soft tissue is very, very nice, protruded anteriorly in the cervical region of that restoration. And this is how the patient started, how the patient was finished. This is the x-ray of the patient before. Remember, there was no buccal bone here. And this is the x-ray of this moment here. My dear friends, what happened? Now I see the buccal bone very thin. You remember that at the time that we placed the implant and we took a CBCT, that was the image. There was a lot of bone in the gap, and we could see that in the x-ray. But something happened. We don't know. Sometimes the bone collapses for some reason. Maybe because we didn't add too much pressure here. We didn't fill the space in the correct way. But please observe the catch and the information that I want to show you. Because the soft tissue graft was added to the case, the volume of the soft tissue is unchanged. So in this case, the volume of the bone was lost. But because we added the connective tissue, we didn't lose the volume. So the volume of the bone may not be the most important aspect in the aesthetics, but the volume of the soft tissue is critical for the longevity of our aesthetics in this situation. And here you can see after 5 years, showing that the buccal bone is very thin, but although we still have the maintenance of the soft tissue volume. In the other case, there was a good volume of the bone, but we lost the volume. Now, although we have lost the bone, we didn't lose the volume because the soft tissue was added. So, my dear friends, do not skip the opportunity of adding the connective tissue graft for your cases. So always fill the gap with the biomaterial. And in the aesthetic cases, primarily, we always use the connective tissue graft in those cases to compensate that loss of the volume, and we see the longevity of our support in that area in a very good way. So I like to mention here my very good friend, Dr. Maurice Salama, and this is exactly what I just showed you right now. So the volume of the bone is very important, but it cannot prevent the soft tissue to collapse. But if you add the connective tissue, even if the bone collapses, the stability of the soft tissues is maintained. So he mentioned this phrase here some years ago, and I was there, and I captured that information. And here, with his authorization, I'm using that phrase. So if I prefer much better a thick soft tissue and a thin bone as opposed to a thin soft tissue and a thick bone. So always pay attention to the volume of the soft tissue there. Okay? And how stable is that? We have cases like many years, like in this situation, we took the tooth out, placed the implant, we did the soft tissue static tissue reconstruction, good prosthetic management. This is 1 year down the line, and this is 16 years down the line, my dear friends. See the stability of that. And that is because we have added the connective tissue graft to that scenario. So if you want to be predictable, if you want to be efficient in your cases, please rely on the benefits of the connective tissue graft to provide aesthetics and clinical satisfaction, but also stability, not only to the soft tissue, but sometimes, or most of the times, to also the bone. And that is related to the predictability of the case. Okay? So with that, I think it's a good moment to stop. And if there are questions, I can answer those questions before we can move on to the next part of the of my presentation. So Beth, can you?
Looks like we have 3 questions at least. The first one, let me see. What's the advantage of covering versus leaving epi collar on the CTG?
Oh, if you don't cover the connective tissue graft with the soft tissue, so you may have a scar or a line separating the connective tissue that was left exposed and the position of the gingival margin, so there will be like a scar in that area. You can have a color mismatch because the color of the connective tissue graft is going to be whitish as opposed to the color of the mucosa apical to that area. So the aesthetics of the color is important, and also related to the vascularity of the graft. So if I cover the graft with my flap, I'll have more vascularization coming from internal part of my flap on top of my connective tissue graft. Okay, so that is the advantage.
So another question is the brand of collagen impregnated xenograft, and what's the make and brand of CBCT that you're using?
We use many cases. Most of the cases that we used here in Brazil, in terms of the biomaterial, is the Geistlich biomaterial, so Bios collagen and BioGuide being used, but I can tell you that Nobel Biocare, they have a great xenograft as well, and I have used sometimes the biomaterial by Nobel Biocare, but unfortunately here in Brazil we don't have it. So all the cases that I used were cases that I could grab it outside Brazil and bring to Brazil to use in my patients, especially the membrane from Nobel Biocare is Krios. Xenoprotect for me is the best membrane ever in terms of uh, elasticity, long-term maintenance, and I can do beautiful cases with that. So pretty much most of the cases, Geistlich biomaterial. And the CBCT here in Brazil, it's the Morita equipment that's most used, and ICAT, the most used brands of CBCTs that we have here in Brazil.
So another question, when covering implant recession case with CTG, has there been post-op epithelial cyst complication?
Ah, very good. So whenever you take a free gingival graft and deepitalize it outside the mouth, if the remnants of the epithelium are left on top of your connective tissue, some cases you can develop epithelial cysts. It's a reality. Sometimes it happens. Not so frequent, but some cases it happens. And if it happens, what is the treatment? You have to kind of do a small cut, like a circular cut in that area that is coming out that epithelial cyst, with the attempt to remove that part of the epithelium that was left behind. Okay, but it's impossible to say uh, when you have left, you're leaving behind the epithelial cells. It's visual aspect. It's very difficult to see. However, if you get the free gingival graft and deepitalize it, you're going to have the lamina propria. So much better to be positioned underneath the flap. So the stability of it is much better when you take the deeper parts of the connective tissue that has absolutely no epithelial cells, because we're taking it from the underneath, but you're not taking the lamina propria. You're taking the submucosa, which has glands and fat tissue, and that tissue is not so stable, very difficult to stabilize, and it tends to resorb through time. So my pick is always to use the tuberosity because of this collagen content. But if I can't use the tuberosity, I prefer to take a free gingival graft and deepitalize it, trying to be careful to remove as much as I can the epithelial cells to have the lamina propria in conditions to use as my source of connective tissue grafts.
So another question, does coronal advancing the flap reduce the vestibular depth?
Say that again?
Does coronally advancing the flap reduce the vestibular depth?
Yes. As I showed you, in one case, in the beginning of my presentation, I mentioned that, that kind of technique very oftentimes produces the distortion of the mucogingival line and the depth of the vestibule. But luckily, after some months, it comes back to its original position. So it's not a problem. So we learned through time that this change in the mucogingival line and the depth of the vestibule tends to return to its original position through time. If it doesn't, then you have to do a vestibuloplasty to finish the case.
So another question, will you be able to show a CT harvest?
Not maybe yes. In the final part of my presentation, there's a video there showing how to do that, and that is pretty much straightforward. I do that every single day. Not a day in my practice that I don't take a connective tissue graft from my patients. So that is the essence of our work, and it's really important that everybody can master that part of the procedure because we do that a lot, and the quality of the connective tissue is so important for the application that we want to use. So in the final part of my presentation, there will be one or two videos there showing how to harvest the free gingival graft or the connective tissue graft in that area. So there will be, if you are patient, you're going to see that. But again, if we can meet personally in Canada in some months, we're going to have a full lecture of that, and we're going to practice that as well on the pig jaws.
So we've got another question. Do we need to mix the xenograft with the autograft?
Good question too. Honestly, we don't do that. Okay, so when I'm doing socket preservation or filling the space with the gap in the anterior to the implant, because it's inside the boundaries of the socket, the healing potential is very good. So if you want to add autologous bone, you are more than free to do it. But I don't do that. I just rely on the benefits and the stability of the xenograft in that area because it doesn't resorb very easily, and it will help the growth of the patient's own bone around the particles of the biomaterial. So therefore, we don't do that, but some people like to add, and that's okay.
And one more question. Any specific prosthetic material you prefer in subgingival contour?
That part of the discussion, I will not tackle too much because I'm not a prosthodontist, so I never do anything related to prosthesis. I do only the surgical part of the procedure, but I can understand the shape of it. So when the prosthodontist is working, I can tell if everything is good by looking the concavities and the shape of the provisional restoration. But pretty much, I cannot say too much about the materials that they are using because that's not my deal. So I'm sorry, but I cannot answer that with the depth that you deserve.
I think that's the end of the questions that I see so far. I'm going to post my email address in the chat. So if everyone can just send me a quick email so that I have the email address that you prefer, that once we get the CE certificates issued, then I'll have everyone's contacts. That would be great. But I don't see any more questions.
Okay. So we can move ahead for the next part. What do you think?
Sounds good. Would you like to have a few minutes just to clear your throat?
No, I'm good. If you are good, I prefer to just let it go.
Okay.
Okay. So let's go for it. So until now, I provided you the information to avoid having complications. So if I have a patient, ideally, I want to do a case in a final in a way that I don't have any static problems. But you might not have a good day. Something may go wrong, or very often times we receive patients like that already with implants made by other people and with a lot of complications. And now you have to learn how to deal with those complications. So what to do here? How to do the suggestions that I'm going to provide you here, and when to do one thing or another, which is a decision tree that I'm going to propose to you. So this is a very important chapter in our work, and we know there are many ways to lead to Rome. So that's something that we say a lot here in Brazil, meaning that for every single thing that you want to do, there are multiple ways of approaching that situation. But here, specifically, when it comes to management of complications in the aesthetic zone, it lacks scientific evidence. So we don't have too many publications, okay? And what we have here, a lot of people with different clinical experiences showing or trying to lead the way to showing us how to do the treatment of those cases. Our group also have been devoted to this topic. So we have one chapter discussing this topic in our book. And in that time, 2015, this was the decision tree that we had, that we felt at that moment that this decision tree could pretty much solve like 80 to 85% of our problems. And that was related to the positioning, the three-dimensional position of the implant, if it was adequate or inadequate, and the deficit or not in the soft tissue. So two parameters here: the deficit on the tissues, hard and soft tissues, and the position of the implant. And trying to connect all those informations, we would suggest a clinical scenario. For instance, if the implant is well positioned, it's adequately positioned, there is no bone defect, but there is a volume deficit in the soft tissues, then we would do the connective tissue graft and so forth. Okay? So we could see, according to this table here, that we were able to pretty much solve like 80 to 85% of the problems. But there was not enough because we couldn't solve all the problems. Therefore, we evolved and reinterpret our own, understanding. And after some years of discussion, we came up with a decision tree, and that is published in this article, 2019, with our group and the participation of Professor Oscar Gonzalez from Spain, pretty much showing the decision tree to remove the implant or to keep the implant according to specific parameters that we're going to see, suggesting a surgical and restorative protocol of treating those cases. I say that, my dear friends, because many oftentimes when a problem arises to you, many people only perform the surgery without changing the crowns. And we think that it's imperative to change the crowns or to remove the crowns in order to find the best solution to the case. And I'm going to be showing you how we do it. So this decision tree is based on three steps. Number one, diagnosis. So what is the problem that you have? Then you're going to evaluate some specific parameters, the critical factors evaluation. And then, of course, based on the diagnosis and the evaluation of those parameters, we're going to come up with the treatment, which is keeping the implant or removing the implant. Okay? So, of course, in order to have a good diagnosis, we must rely on the clinical and radiographic evaluation. So we have to probe the area to see if there is bleeding or not, if there's pocketing in that areas. We have to see the X-rays, like not only the CBCTs, but also the interproximal images, like the periapical X-rays, in a way to check the height of the interproximal bone. And in order to see internally the area, to check the angulation of the implant, and to check if the prosthetic interface is intact or not, we would suggest very strongly that you remove the crown in the diagnosis area moment to further observe those parameters. Okay? And then we're going to check the three critical factors that will lead to the decision tree. So number one, peri-implantary status. So we have a healthy aspect, or we have inflammation and bone loss, peri-implantitis. Completely different story. We all know how hard it is to remove, to decontaminate an implant. What is the position of the implant? Is it adequate? Meaning that can it be restored? Or is it so badly positioned that we have to take it out? And the condition of the prosthetic interface. That is so important to remove the prosthesis, to check if this area here of the interface of the neck of the implant is intact or damaged. And based on that, we're going to suggest the treatment path. If I have a healthy situation, meaning that there's no peri-implantitis, as we know, if the implant is adequately positioned, I know that sometimes this word adequate can be challenging to understand, but the thing is, can you use an angled abutment to create a better access for your restoration? That would mean for me adequate, even if it's buckly position or tilted in a way. If you place an angled abutment, you would be able to use that implant or to restore that implant in a very nice way. All right, so we have to check that. And so if the prosthetic interface here, the connection is intact, if you have situation like that, we would preserve the implant and reconstruct the soft tissues in that area. So if, my dear friends, I don't have peri-implantitis, if the implant can be restored, even if you have to use angled abutments, and if the prosthetic interface is intact, we're going to keep that implant and we're going to reconstruct the soft tissues. I'm not talking about bone here. I assume that we're not going to do anything with bone in cases like that. The question is, what kind of soft tissue? And the answer is, where is the problem? Is it in the static zone? If it is, we're going to use the modified envelope and the connective tissue graft. But if you are talking about the non-static zone, like the posterior region, then for sure we can solve the case with a 3D graft, which is very simple, very reliable, very easy, but the color is not going to be so good, but it's a non-static area. Okay? So, I'm sorry. So, specifically in the static zone, it is critical for us to remove the crown in such a way that we can check the angulation of the implant, we can check the integrity of the implant platform, and we also create the adjustments in the abutment in a way that we can create space for our surgical access and the positioning and stabilization of the connective tissue graft. So it's imperative that we remove the crown. And I say that, my dear friends, because I know that many of your patients, when they have a problem, they don't want to remove the crown, to lose the crown. They say, doctor, but I paid a lot of money in this crown. I want to keep it. And you have to say strongly, but you can't. So if you want me to treat your case, it's imperative that I take the crown out to create a space and to make the adjustments for the graft positioning and stabilization. That is very important. And maybe we are the first to suggest this kind of surgical and prosthetic protocol in the treatment of those cases. So it's very important that you do that, to create a space, to create the surgical access for the graft and the stabilization, and to evaluate the device adaptation, and of course, the integrity of the um, um, implant surface. Please observe here how the patient presented, and you can appreciate here that this bulkiness of the ceramic all the way to the gingival margin. How is it possible to try to cover this if you have the ceramic like that? So we have to take it out to create a space for the treatment that I'm going to be showing you in a moment. So it's imperative that we take the crown out to create those adjustments. If you have, on the other hand, periimplantitis, if you have an implant that is very badly positioned, in which that not even using an angle abutment, you cannot restore the tooth, or you have a damaged implant surface like this, like interface, which is broken, of course, we're gonna remove the implant. And if I'm saying I remove the implant, it means that I'm growing the bone and the soft tissue. So please pay attention. If I decide to keep the implant, I'm going to do a soft tissue graft. But if I take the implant out, I'm going to do a bone and soft tissue graft to restore the case and place the implant in another moment. Having said that, and that is the decision tree, are those cases equal or different? Are they similar or they are different? They are similar in the sense that both patients have problems in the aesthetics in the anterior zone, but they are very different in the way we managed those cases regarding the diagnosis and the observation of the critical factors that I just showed you. So let's see 3 cases here to highlight this situation. The first case is this one, in which you can appreciate that the patient has a high smile line, okay? And she has this height gingival recession problem here. So height discrepancy in that area. Remember that I mentioned to you that sometimes the patient had a high smile line. This is like a billboard for us. So if something happens, everybody gonna notice. And this patient is very miserable because of that. She doesn't like the way she appears. She doesn't like to smile because that shows that situation. And when we see that like more in close, you can appreciate why that happens. Yes, she has other problems, but this is sticking from my eyes. I can see that in advance. So this is the CBCT, the X-ray of the patient. We see here there's an implant, but this is the most important aspect here. Here you can appreciate that there is absolutely no palatal bone, okay? And I can tell you there is a big pocket in that area. There is infection there. There's pus coming out. And of course, you have the loss of the volume of that area, okay? The buccal bone seems to be very thin in this area, but there is no palatal bone in that area. And we have already here exposed threads on interproximally and completely on the palatal aspect. So in this case, we have periimplantitis. So there's infection here. There is a very buccally positioned implant, so there's no way that we can restore this, although the interface of the prosthesis of the implant is intact. But because of these 2 situations here, we suggested the explantation, the removal of the implants. Okay? So on the occlusal aspect, you can see that the volume deficit. So the first thing we did here was to remove the crown and the abutment, and also prep the adjacent tooth. And here we can appreciate, the new provisional restoration with the space for the reconstruction here. The implant was removed in a very easy way. So this is the retrieval tool, okay? So from Nobel Biocare. So they have this kit, which is unbelievable, to remove implants in a very, very easy and fast way. So the implants are removed, and we know that sometimes it's very hard for us to remove the implant, but in majority of the cases, the reverse torque here using the retrieval tool will be more than enough to remove it. And generally speaking, we take a implant out in 1 minute. So if it doesn't come out in 1 minute, it will take 1 hour to take it. So it's either 1 minute or 1 hour. And the majority of the cases, it's 1 minute if you use the retrieval tool. But sometimes the internal part of the implant is damaged, so you cannot engage the retrieval tool there, or the retrieval tool can break. Therefore, you can use the piezo or the burrs to remove that implant. So here, implant was out, and how we managed the defect here. There are multiple ways of doing that. So this is the way we did it at that moment. If it was today, I would have an approach in a slightly different way. But at that moment, we decided to open a palatal flap, as you can see here, not a buccal flap, but a palatal flap. We removed the content of the nasopalatine canal, the incisal canal here was removed. So we cut it with the blade and use a burr and curette to remove all the content here of the nerve and the vessels. And we filled this area with the bone from the tuberosity. So we went to the tuberosity, we harvested some bone from the tuberosity, and we packed not only inside the socket, but also externally on the palatal side, inside the nasopalatine canal, and also recreating the palatal wall that was missing. If it was today, I would probably have added a membrane here, like a collagen membrane, and of course, some xenograft to protect that bone graft from the tuberosity. So here you can see the bone that was packed not only inside the socket, but also inside the nasopalatine canal and reconstructing the volume of that area. And on the buccal aspect, we decided to create a pouch here in this area, preserving the papilla, and placement of a connective tissue graft underneath. And this is how the patient was finished. The surgery was finished here. So a lot of sutures. And the provisional restoration was delivered for the patient. And now we have to wait the healing time. And here you can see what happened after 6 months. Please observe that the height of the tissue was recreated. So we were able to bring the tissue coronal in a very good way. But unfortunately, we lost the volume. So although we did what we did, yet we had some resorption here in that area. But when you look the CBCT in terms of the bone, you can see that the quality of the bone is pretty much nice, showing the benefits of using the bone from the tuberosity, okay? But I agree that we could have created a little bit or more bone if we have added here a membrane and some biomaterial. But yet, the bone is good, and we can move ahead, open a flap. We're able to place the implant, okay? And because we lost the volume, but we felt the bone was good, we decided to add a connective tissue graft from the tuberosity. So now we added another connective tissue graft to the buccal area in a way to create a bulkiness in that area, using the graft from the tuberosity. The bone was added a little bit, just to recreate a little bit of volume, although the bone was good, a little bit of more extra bone here, and the soft tissue was recreated here. And then we closed the area. We sutured everything in a good way. Please observe now that by the addition of that bone support, but most importantly, the connective tissue graft from the tuberosity, now we have a great volume in that area. And this is the patient after 6 months. We can see now the bulkiness in this area. Remember, there was a deficit there. There was a concavity. Now we have a convexity in this area. So at this moment, we're able to remove the crown and the cantilever on the other central incisor. We did just a tiny gingivectomy in the center of the ridge, like a punch technique, to remove the helium cap and to place a provisional post. And on top of that, relined a provisional restoration. Please observe that our prosthodontist here was instructed to keep the embrasure open. So they want to close this area. And we tell them, please do not do that. Because if you close this area with your resin, I know that the soft tissue will not have the chance to grow. But if you left it open, it can grow. Sometimes it won't, but sometimes it will. And you have to give it a chance. All right? So it was left like that. And this is the patient after he finished. So after the treatment was done, we can see that there was only a tiny improvement here in the papilla. Maybe the distal papilla even increased a little bit better than the medial papilla, but now you can see the volume of that area. Okay? See here how it was. It's out of the out position here, and this is the final restoration. So this was the provisional restoration, and this is the final restoration. Please observe that the distal papilla improved, but the mesial papilla did not improve at the same level. But please observe the volume of the soft tissue, and please also observe that. And by the way, this happens very often. When you have an implant supporter restoration and you have a tooth-borne restoration, very oftentimes the gingival margin of the implant supporter restoration is even better than the tooth because of the way it comes outside from the bone. Okay? And there is no space there or the gaps between the tooth and the prosthesis there. And therefore, we have a great clinical outcome. So this is how the patient started, and this is how the patient was finished. Maybe not perfect, but please observe how we started and how the patient was finished. And this is, my dear friends, 10 years outcome. This is not 1 month. This is 10 years outcome. Coming from this situation to that situation. And this is related to our decision of taking the implant out because it was not possible to keep it. And of course, doing the bone and the soft tissue architecture. And here you can see the patient when she started and at 12, 14 with 10 years follow up in that patient. Right? I mean, 11 to 21, 10 years follow up. Great clinical outcome. What about this patient? High smile line, or median high smile line doesn't show too much, but the patient is concerned about this because now the tissue is moving in the apical direction, and she has some pain when she starts to brush this area. So the patient is very concerned, and you can also see that there's no periimplantitis here. There's no inflammation, but we have this gingival recession take place here. When you look at the CBCT, you can see here that the tip of the implant is inside the nose cavity. Imagine yourself, my dear friends, taking this implant out. And how is the reconstruction of this area here? Not easy, not easy. So please do not condemn every single implant that you see that is not so well positioned. Try to give a chance. But of course, you have to take the crown out. You have to evaluate the critical factors to make a decision. So here we took the crown out. And by the way, the patient did not want to remove the crown. She said, "Doctor, I paid a lot of money." And we have to tell her, "I'm sorry, but you have to take it out in order for us to evaluate the critical aspects and to create a space for the resolution of the case, and also to observe the integrity or not of the implant platform." So we can see that the implant is not well positioned. It's buccally positioned for sure. But the question is it possible to use angled abutment or some kind of prosthetic solution to restore that implant? Okay. Is there periimplantitis? And how is the prosthetic interface? So it was healthy. There was no periimplantitis. The implant was not well positioned, but we felt that using an angled abutment in the end, we could solve the case, and the prosthetic condition was intact. Therefore, we're going to reconstruct with the soft tissues. So this is the new provisional restoration. In this case, at that moment, we could not get, at that moment, the angled abutment, but yet we can create the design of the provisional restoration with this exit in the buccal aspect here, but in the cervical region, creating the concavity in that area to create a space to place our graft in that area. And please observe that we try to mimic the CJ from one side to the other as great as we could. And now we do our procedure that we described, and that is the modified envelope. And please observe, my dear friends, somebody asked about the vestibule loss. And here you can appreciate that is going to happen. So after the flap was, or the envelope was created, here we're using these microblades to dissect the apical direction to bring the tissue in the coronal direction. And this is a tissue from the tuberosity. So a connective tissue from the tuberosity that was opened like that, like a chicken breast, okay? And we're gonna place it underneath the pouch. And here you can see the two sutures, mesiodistal, the connective tissue that is exposed, but now we want to cover everything. And by using those sling sutures around the contact point, you lose the volume of vestibule depth, as somebody asked. But now I cover the connective tissue graft. So there is a gain and a loss here. In those cases, or in this case, we also used amelogenin, so endogain, to help the healing of the soft tissues. This is debatable, but we like to use it to help the healing of our patients. And this is the patient after 6 months. So after 6 months, the vestibule already in its original position. The mucogingival line is in its original position. But please observe the volume of the soft tissue that we have right now. And we have like 100% root coverage in this situation. So this is the comparison, how we started, how we finished the case. There was no keratinized tissue or minimal amount of keratinized tissue. Now there's a thick and wide band of keratinized tissue cervical to the CEJ of that area. And the height of the gingival margin completely different right now. There was a big recession. There's no recession. And you can see the comparison here. I would say a fantastic outcome. And that is the lateral view. How, my dear friend, is it possible to recreate this volume if you don't remove the crown? It's just impossible. Therefore, it's imperative to remove the crown. Therefore, my dear friends, this is like, as I mentioned to you, prosthetic and surgical um, protocol that is required to solve a case like that. This is the patient 1 year after the delivery of the final restoration. The patient is quite happy, and now, of course, they have to check this patient through time to see how stable it is. But you can appreciate that we are able to change completely the scenario. The occlusal view showing the volume of that area in a very good way. And to summarize this kind of approach, there are a lot of longitudinal information on top of that. So we don't have the scientific evidence in high power to show that it works. But we have the midterm stability of those cases, as you can see here, if we understand the impact of the evaluation of the critical factors here in the best way possible. And it's imperative or a requirement to remove the crown, to create a space for us to place our connective tissue graft and stabilize it in the best way possible and favor a good prosthetic management. So it's surgery plus prosthesis working together to solve the case in the best way possible. All right? So are they equal or they are different? They are equal in the sense that there was a static problem, but they are very different in the way we approach those cases. One, we decide to keep the implant. Another one, we decide to remove the implant. And yet, we have had here a very nice final outcome related to the observation of our critical factors in the best way possible. So we, in one side, we reconstructed the soft tissues only. The other side, we have to remove the implant and reconstruct the bone and soft tissues prior to start over again with a new implant in that area. And you can see that both paths of treatment ended up with a very nice clinical outcome in those situations. Very well. Let's see a final case here to finish this topic. So a very, very challenging case. So everybody here would agree that this is like a borderline case. A lot of recession in this implant, a lot of discrepancy in the height of the soft tissues. We have here, for sure, teeth that are not so well positioned in that area. And in terms of the implant, you can appreciate here that this is like external hex implant with some bone loss in the buccal area and interproximally as well. So for sure, a borderline case. But can we improve the case prior to condemning this implant uh, as a first choice? Because we don't have periimplantitis here. It's not like a suppuration. The implant is buccally positioned, but can you correct the angulation of the prosthesis by placing an angled abutment? And by removing the crown, we saw in this patient that the prosthesis, the implant platform was intact. So let's try to give a chance. I'm not saying that this implant is going to be saved, but I'm at least will create a better soft tissue architecture prior to my final decision. So the crown was removed of both teeth, implant and implant here, okay? You can appreciate that this implant is very buccally positioned, okay, in that area. But we took an impression and we placed here a new post on the tooth, okay? And then we prep that, and then we delivered for the patient this new uh, angled abutment, okay? So a custom abutment with the angle screw incorporated with in the concept here. And this is the new provisional restoration on top of the tooth and on top of the implant. And now, my dear friends, what you see here is a gingival recession around the tooth, exactly as I showed you before. So we transformed the case in a case of a gingival recession. And how do we treat a gingival recession? As I mentioned to you before, that is using the modified envelope. So here, removing the crown, we're going to remove the abutment. This is the micro blade that we're going to use here interproximally. But just after that, we're going to change for the tunneling instruments adjacent to the implant, but here in the center, always using the microblade. So here, this is the tunneling instrument touching the bone. So this is full thickness flap, so adjacent. Have to take your time to do that. Very careful. And then after you move beyond the mucogingival line again, you have to use the microblades to cut the fibers. So here we are still using the tunnel instrument, but you have to use the microblades in that situation. And now we can check the mobility. Please observe the tissue is coming, but there's still a little bit of tension here. So that means we still have to work a little bit more. So here we are extending laterally our envelope. So we have to extend a little bit more. This is it, my dear friends, the removal of a connective tissue graft from the tuberosity. So this is like a removal of a block of tissue from the tuberosity, very thick tissue. And now we're going to remove the epithelium. So de-epithelialization. And then we cut in half like a chicken breast. And this is going to be used in that area that we just saw. So here you can appreciate the connective tissue graft from the tuberosity that will be placed underneath the flap. So first I engage the needle in the base of the papilla, then I grab the connective tissue, then I come back internally and I push it and I make it go inside, one side and the another. Please observe that we are trying here to make the connective tissue graft to be stretched in the level of the CJ. And if I leave the patient like that, there's no change in the vestibule depth. But we want to cover that. So here we are adding another suture to kind of tight the connective tissue graft around the neck of our restoration. So to provide extra stability to that area. And now we are bringing the connective tissue, the flap on top of the graft in a way to cover as much as I can. But please observe this, the vestibule that has been lost. And this is a consequence of the procedure here. But now we have to wait. And if it doesn't go away, I know that in the future I have to do a vestibuloplasty in this area. But check what happens. Through time here, 2 months, you don't see as much uh, uh, change anymore in the vestibule depth. We have to wait, of course. And this is like 6 months, in which now you have a beautiful amount of keratinized tissue. There's no vestibular deficit anymore, so there's no change in that situation. And now we have leveling of the gingival margin. So now you have to make a decision. Who among us you would remove this implant right now? So should I remove this implant or I should just restore it because everything is very nice? So, in our opinion, much better to keep it right now because everything is solved. So here, the final case is here. You can appreciate how we started, how the case was finished, keeping the implant there. So I'm not saying that nothing's going to happen in the future, but at least we could solve the case for the moment with a very, very nice resolution of that. And this is how we started. This is 1 year after. And please observe the vestibule is restored without any surgical procedure. Okay, my dear friends. So do not anticipate the removal of your implants. Try to check if it's possible or not to keep that implant, at least for the moment, for the improvement of the soft tissues. Okay? And understand that you might have to perform multiple surgeries to solve cases like that. But the most important aspect is the diagnosis. So, what is the condition of the three critical factors? And then you're going to choose the path. Remove the implant and reconstruct bone and soft tissues, or keep the implant if you feel like it's good alternative and restore only the soft tissues. That is it. So if you have questions, this is the moment to answer them.
I don't see any new ones at the moment. Oh, there's one. Can ADM work as well?
No, we don't believe those biomaterials, rather than the connective tissue, can have the same clinical outcome. Yes, they can work in the sense that they can be used, but we haven't seen so far the same kind of clinical performance. So, in our opinion, in this kind of cases, the connective tissue graft is still the gold standard. And unfortunately, we don't have any substitute for the connective tissue graft. Also, very important, the quality of the connective tissue. In those cases, specifically, very important if you can use the bone from the tuberosity, the soft tissue from the tuberosity.
That seems to be it.
Okay? We still have 1 more hour to go. So,
Oh, sorry, there was one that popped up. Why is it better from the tuberosity
because
versus palate?
because the tuberosity is much more dense as opposed to the palatal aspect, and it's much more firm, and the collagen contact is better and more stable, therefore. And the connective tissue from the tuberosity has a potential to grow overgrowth. So in those deficit cases, the benefit, the long term, growth of that tissue can further improve our outcome. So for sure, the connective tissue graft from the tuberosity, on that regards, has an advantage on top of the palatal tissue. But remember, if the patient doesn't have a good tuberosity because of the presence of the third molar or the opening of the patient's mouth cannot allow us to remove a good connective tissue from the tuberosity, then for sure we have to rely on the palatal tissue. And uh, if it happens, I have to go to the palate. And in order to have the best quality possible from the palate, I would take a free gingival graft from the most posterior area, okay, not the anterior but posterior area, and deepitalize it outside the mouth to have the lamina propria. So the most posterior area of the mouth, it seems that the thickness of the palatal tissue is thinner as opposed to the anterior part. But the lamina propria of the posterior area seems to be a little bit thicker than the lamina propria from the anterior part. So I want the lamina propria. So I prefer to go more to the posterior area, okay, in order to have the best quality possible. Then I harvest a free gingival graft and deepitalize it to have the best lamina propria if I can't have the tissue from the tuberosity.
That seems to be it.
Okay, so it's only 1 hour to go, and I think now we're gonna change gears to a much more challenging situation. And sometimes we face patients like that in the office and big deficits in the bone, and we have to understand what it's possible to do. So in the clinical reality of our practice in the everyday office, sometimes there are patients that just don't have any bone or patients that do not allow us to place the implant in the best possible position. And if that happens, in order to seek for the excellence, you have to think about bone augmentation to reconstruct that area in the best way possible. You can perform the bone augmentation in 2 moments. You can do that staged, meaning that I'm going to first increase the volume of the bone prior to the moment of the implant placement, or eventually you can do the simultaneous approach, meaning that I'm going to place the implant and I'm going to reconstruct the bone that is missing because of the exposed threads at the same moment of implant placement. Therefore, a simultaneous approach. I know that the benefits of the simultaneous approach is very interesting in terms of the speed of the treatment. So if I do simultaneous approach, the treatment time is going to be reduced. So also the morbidity related to that because the number of procedures will be, reduced and the cost related to that. So it's very interesting to think about simultaneous approach. However, when it comes to those bigger cases, it's very easy to lose the proper three-dimensional position of the implant, especially if we're treating multiple cases. And do not forget about the risk of dehiscencies or the sutures opening that shall expose the graft material that can lead to infection. And this infection, if it gets to the implant surface, it's very hard to come back to a normal track again. Therefore, you have to think about very carefully if you are going to do simultaneous or staged approach. We have a decision making process here. So, sorry. So if I'm able to place the implant in the right position, despite of the bone defect, and if I'm able to close the area in the best way possible without tension, okay, in those situations you might consider performing the simultaneous approach. But if you think about that is not possible to place the implant in the best position possible regarding the anatomy of the defect, or you think it's very risky to have an opening in that area that may lead to infection, it might be better off to perform the staged approach, meaning that you're going to first recreate the bone and then you have a secondary moment to place your implant. And at that moment, you can even increase a little bit more with some bone augmentation simultaneous to the implant placement. Okay? Regardless of that, the clinical objective is very simple. So my objective here, when I see a case in which there is a deficit in the bone, height and volume, is exactly to recreate that volume. So by applying different techniques of grafts, membranes, blocks, whatever. The final clinical objectives for sure to reconstruct the region, the height, and the volume so that we can place our implants ideally and a bone that is living and very hard, as you can see here in those two pictures. So sometimes we have very dramatic case such as this one, and we can come up with a beautiful bone like that by adding one or other clinical alternative. And that now allows me to place the implants inside the bone that is reconstructed in a very good way. And the moment of the truth is this one, when we have to reopen the site and check the quality of the bone that was regenerated. And here, coming out from this, we're able to come out to that. So that is pretty much impressive. And these some millimeters of bone, sometimes 2 millimeters, sometimes 10 millimeters of bone, sometimes 12 millimeters of new bone, is not only growth of bone, it's a possibility to change the life of our patients. Because here you can see three different patients with three different backgrounds, with three different objectives, but they share in common one simple thing, the fact that they don't have the bone to place the implants where it should go. And if we apply the proper techniques in terms of regeneration, we're going to recreate the bone. And if you are able to recreate the bone, now it's possible to place the implants in the best way possible. And that can reflect the smile of the patient in a different way. So that is a change in the functional, the emotional, and the aesthetic aspects of our patients. So, therefore, my dear friends, bone augmentation is not only growing some bone, it's the possibility of having a very, very powerful asset in your clinical practice. So, that is something very important. What are the techniques that we can use? There are so many. But for sure, the most widely used techniques to recreate the bone is the bone block, autologous bone block, specifically the intraoral bone block, or the guided bone regeneration. So the bone block is that technique that we're going to harvest the bone from maybe the ramus or from the chin, and then going to place it in another area in a way that is going to recreate the volume that we want. Or we can use a membrane and particulate material underneath that membrane, covering or recreating the volume that we want, protected by the membrane. And therefore, this is the concept of guided bone regeneration. Both techniques can be used, they are nice, and they were improved with time. So today, if you are a lover of the bone blocks, you can do a better job today using the so-called bone plates, in which we harvest a bone block and we cut that into small plates, and we can create like a shelf, buccal, lingual, maybe occlusal, and underneath that we pack autologous bone. And today, we can also do the GBRs using custom abutments, custom devices, such as the titanium mesh material. We can use zirconia. We can use other kind of devices printed to recreate the volume that we want in a much easier way. In my humble opinion, now I'm speaking by myself. I'm not representing here Jolie and Paulo because, for instance, Paulo likes much better to do the Curie technique, which are the bone plates, but I prefer personally much better doing the guided bone regeneration. In my perspective, I think that the guided bone regeneration is the most versatile procedure because it doesn't matter the size of the defect. Doesn't matter where it is, if it's horizontal or vertical. I can always put a membrane on top of that. And that is extremely predictable, but it's a very sensitive procedure. Therefore, my dear friends, be aware that it's not easy procedure. It's a very sensitive procedure, very demanding procedure. And of course, that we rely on the guided bone regeneration principle, which is the osteopromotion. And that means to use a membrane covering the defect. And there are basically two kinds of membranes. There are the non-resorbable material, like the membranes here, and you can also use a titanium mesh, but covered with a collagen membrane to fulfill the principles of the guided bone regeneration, which is not allowing the cells to migrate from one place to another. And you can have also the resorbable material, which is much more friendly, tissue friendly, as opposed to the non-resorbable material. So generally speaking, we prefer, or it's indicated to use the more sophisticated materials like the titanium reinforced barrier membranes, non-resorbable material for the vertical defect because it better contain and stabilize the biomaterial. But when we have like a horizontal defect, it's much better off to use a much more simple device, which is the collagen material. So we don't need to use a non-resorbable material in a defect like this. Okay, so a more difficult case goes for a more sophisticated membrane. But if you have an easier case, we use like a more simple material like a resorbable membrane. Here, my dear friend, everything matters. Everything matters. It's a very, very sensitive procedure, and everything matters. The success of guided bone regeneration requires a very strict obedience to the surgical technique, and it goes from the incision to the suture. So, if we have the opportunity to be together, I'm going to be showing you one full day of tips regarding from the incision to the suture. There are a lot of things to be highlighted here in a way that we can have a good clinical outcome. So here, everything matters. So either from the source of the biomaterial that I'm going to be using to reconstruct the bone, uh, how and where I do my incision, how do I elevate the flap, if I'm using or not the tenting screws, how would we perform um, um, the corticotomy, if the corticotomy is required, what membrane should be used in terms of the defect that I'm going to be using. I'm going to use growth factors or not, and how we suture that. So, my dear friends, it's very sensitive, and everything is so important here to achieve a good clinical outcome. So, uh, the diagnosis first. So here it's important to understand what is the defect that you are treating. And basically, there are two kinds of defect. There is the vertical defect and there is the horizontal defect. A vertical defect is defined by having bone peaks adjacent to the defect that are more coronal to the base of the defect. Meaning that if you connect one bone peak to the another bone peak, you're not going to have a straight line, but you have this line, like curved line like that. So the base of the defect is more apical than the bone peaks adjacent to the defect. And then you have a horizontal defect in which the line connecting one bone peak is straight and it's lined to the bone level of that area. There's no depth in that area, in that situation. When I have a horizontal defect, there are two kinds of horizontal defects. There is the so-called favorable defect, in which you have the cortical plates here, and you have the medullary bone, and you have this unfavorable defect, also called knife edge situation, in which you don't see the medullary bone here or the medullary spaces here in this area. So very thin, very uh, without any cells, without support, without vessels, without growth factors. So much more unfavorable situation. The predictability in terms of regeneration is also very important. And in order to understand the potential of the bone augmentation, you have to observe the interproximal bone peaks. So, in terms of height, how much bone you can grow? You have to see the interproximal bone peaks. So that is the amount of bone that you can grow in the vertical direction. Sometimes when you have the discrepancy in the height, in the mesial and distal part of the bone around the tooth, sometimes we have to extract that tooth in a way that now we have a better bone peak to have a better vertical dimension that can be growing in that situation. And in terms of the horizontal potential, so generally speaking, it is within the boundaries of the adjacent bone peaks, buccal and lingual. So the bone prominences of the buccal and lingual aspect will determine the width of the reconstruction in the area that is missing bone there. And you have to determine your device to reconstruct that area. Remember, there are resorbable and non-resorbable devices. So generally speaking, these non-resorbable devices goes well with the vertical defects, generally speaking. But when you have a horizontal defect, the resorbable material goes much better with that. And here specifically, the best membrane for me is that I like to use very much is the Krios Xenoprotect. Very, very good membrane because it stretches much more and I can give a perfect volume of bone in that area. So depending on the defect, I'm going to choose the kind of material that I'm going to be using, a non-resorbable versus a resorbable material. But regardless of that, the mixture of bone graft is like this. At least 50% of autologous bone to the remnants of the biomaterial and xenograft here. So the bigger the defect, the more percentage-wise I have to be using the autologous bone. Let me say that in a very drastic case, I like to use like 75, 70% of autologous bone, 25, 30% of the xenograft. But if I have a more favorable defect, like a horizontal defect, I stick to the 50%, 50% rule. So depending on the defect, I choose the membrane. And underneath the membrane, the mixture of autologous bone and xenograft. The bigger defect, the more percentage-wise I have to be adding connective, the bone graft, autologous bone graft to that area. And of course, that if you want to increase a little bit the predictability, you can always add some growth factors. I like very much to use the LPRF concept because it helps me to create a sticky bone, okay? And it favors the adaptation of the bone in the area. So having said that, let's see two cases to finish. A typical case here from the posterior mandible, very demanding case. You can see the height of the vertical component. Literally here, we see in the floor of the mouth here. So there's nothing here. And you can also see that the cheek of the patient is at the same level of the crest, meaning that there's absolutely no bone there in that area. So this is the X-ray of the patient showing the bone peaks adjacent to the defect. So I'm always looking at the height of the bone peak adjacent to the defect at the tooth related to that. So if I have a discrepancy in the height, several times I extract the tooth to have a better bone peak. In this case, the bone peak is very good. So not only on this tooth, but also on the distal one. So I'm going to preserve those two teeth and I'm going to go for the surgery. So crestal incision Very important to be very precise in the incision. I can place or not the vertical release incision here in the anterior mandible, but for sure, I will create a vertical release incision in the distal to facilitate the harvesting of the bone graft in that area. So also intrasulcularly around the adjacent teeth in the lingual part, and then we reflect a full thickness flap. In this case here, being very careful with the mental nerve. Here we are exposing the posterior mandible where I'm going to harvest the bone. And this is the easiest part of the surgery. That is a release of the lingual flap. Many people has a lot of difficulty doing that, but in reality, this is very easy. In the mesial part of the flap here, towards the premolar area, it's a little bit more demanding because we don't rely on the muscle. In the posterior area, we rely on the mylohyoid muscle. It's only a stretching of the muscle. But in the premolar region, anteriorly, we have to kind of score the periosteum to, create the mobility of the area of the flap. Here we are removing the bone graft from the posterior area using a burr and a scraper. So auto chip maker burr and the safe scraper are used. Here using the tenting screw, and the height of the tenting screw has to be lined with the bone picks in that area, performing the decortication, and that is to create holes in the bone to make the bleeding in that area and create the access for the cells and the growth factors. The membrane is now being applied, and here I'm using the screws to stabilize the membrane. Today I don't use screws anymore. Today I use a special device like a tech that oscillates, and it's much easier and convenient to stabilize the membranes. But here I'm using the screws, one mesial and one distal. And this is the sticky bone made of like 60% of autologous bone and 40% of xenograft and RPRF to create the sticky bone. And now I have to wrap the membrane toward the buccal, and the height of the membrane will be maintained by the tenting screw. So that's why I think it's important, in my opinion, to place the tenting screw, because that will prevent the collapse of the membrane. And then we stabilize the membrane buccally with the screws, being careful with the nerve, which is right here. You can see that the membrane is touching the teeth, so that cannot be allowed. To have to remove that excess of the membrane material to create a space between the membrane and the tooth to avoid contamination. And this is the scoring of the periosteum in the buccal area, in which we just score the periosteum and then we shave the area internally with the back of my blade. So that is a back and forth motion, like shaving that area. I'm not cutting the area, but only stretching the fibers and cutting some of the collagen fibers. So here we are covering the edges of the membrane. I don't do that anymore today. I don't think it's required to use a collagen membrane, but I like very much using RPRF because that helps the healing of the soft tissues. And this is the horizontal matrix suture, which is the most important suture here to adapt the two flaps together, averting the flap. So that brings the connective tissue against the connective tissue. I don't want to have something like this. I want to have something like that. And that is created by the horizontal matrix sutures. And then, of course, after we do the horizontal matrix sutures, we perform the sling sutures or the other kind of sutures to tight the borders in a way that there's no space there and to seal that area. Here you can appreciate the very nice healing after some months, in which now the height of the ridge is completely restored. And if you compare how we started, how we finished this part of the procedure, it's unbelievable. And here you can appreciate as well this X-ray, comparison, in which we have now here the height problem. Here it's stretched like a straight line, meaning that we are able to reconstruct internally that volume in a very, very nice way. The CBCT is very important to show the quality of the bone and the shape of the bone. So here we can appreciate that we are able to reconstruct the bone in a very good way, all the way up to the membrane. And of course, now it's easy to think about placing implants accordingly. So as I mentioned to you, I like very much the concept of guided implant placement. I think it's more reliable. And here you can appreciate the surgical guide in position and then reopening of the site. And by the way, we are able to create the bone, but you could notice there was absolutely no keratinized tissue there. There's only alveolar mucosa, which must be addressed in a different moment. So after we elevate the flap, we expose the membrane, and we remove the membrane, you can appreciate the quality of the bone. So very often times, or the majority of the cases, when you take out this material, which is a non-resorbable barrier membrane, you're gonna see this non-mineralized tissue that is called the smear layer or a non-mineralized tissue. There's not bone. So you scrape that off, and then you're gonna see the new bone formation, which is lined here to the height of the bone screw that was placed there. The drilling was performed and the implants were placed. And in this case here, we also added in this moment like alternative to the connective tissue graft, it was like a fibro guide to increase the area. Here you can appreciate the surgery. I'm going to move it because we saw that already. So this is the bone that we scrape. That's mirror layer that I mentioned to you. And now this is the bone that we can have. And now we can really place the implants in the best way possible. So the quality of the bone here was amazing. Very nice quality bone. And of course, we place the implant here, oriented by the surgical guide. And then, of course, we suture the case. And here you can see how we started the regeneration of the bone, which was amazing, and the placement of the 3 implants. So completely embedded in the new regenerated bone. Unbelievable. And this is the patient after the healing took place, where you can appreciate that now we still have a problem. And the problem is the mucogingival problem. There is no keratinized tissue here. If you dare doing your procedure, final procedure in a situation like that, that is the beginning of a nightmare for you. Because if you don't recreate the keratinized tissue, the patient is going to have this mobile mucosa that is very difficult to clean, that creates a lot of discomfort. Therefore, there's no resistance in that area, and the patient is going to develop, very likely, periimplantitis. So we have to think about the soft tissue here, recreation, in a way that you can have a better stability of that case. So this is the moment that we decided to place, we changed the abutments that were there. See here, it was short abutment. So my colleague here, he gingivectomy here, this area, in this area, and replaced this short to high abutments. And they took the impression. And then he created a provisional restoration. And when the provisional restoration was ready, now we did the mucogingival surgical procedure, and that is the repositioning of the alveolar mucosa in the apical direction, and this is called vestibuloplasty. So you can see that I'm stabilizing the alveolar mucosa in the apical direction. And this is the free gingival graft that was taken from the palate and was stabilized in the recipient site using uh, sutures. Okay? Of course, needless to say that the creation of the recipient site was sharp dissection. So we did a sharp dissection to leave the periosteum on top of the regenerated bone. We apically repositioned the alveolar mucosa, and then we stabilized the free gingival graft in that area. And now, as I mentioned to you, the provisional restoration was already done, ready, and my colleague here just placed the provisional restoration. This is how the patient is healing very, very nicely after 2 weeks. You can see there is no necrosis here, and this quality of visual aspect after 2 weeks is very, very nice for us who perform this kind of surgery because I know at this moment that there's no necrosis here. So very nice healing in that area. And this is how the patient healed. Now we have a good band of keratinized tissue, cervical to the restorations. And when you look in the occlusal aspect, you can see the presence of this very nice band of keratinized tissue there, resembling the adjacent area. So that is impressive. So here we were able to create the bone, the soft tissues, and the stability of that. So this is 2 years with the provisional restoration. 2 years with the provisional restoration in place. Because of some financial aspect of the patient, she decided not to place the final prosthesis. And you can see the stability of the bone here after 2 years. And then finally, the patient decided to finish the case. And this is how the patient was finished. And this is 5 years of maintenance in which you can appreciate how we could start and where we could get in terms of the regeneration and the quality of the soft tissues in that area. So pretty much impressive what could be done here. And let me show you the final case and how we manage complications, some of the complications. This is another chapter, very important, that has to be discussed. And again, if we have the chance to be together in Canada, I'm going to be also talking about the complication management in a much more extensive way. But this is a Brazilian patient that lives in Argentina. Okay? So she's a Brazilian, but she lives in Argentina. And there she lost two central incisors, and it was done one implant for her. One implant was inserted in her upper maxilla, and she also performed a GBR, a guided bone regeneration. But unfortunately, as you can see here in this clinical picture, there was an exposure of the membrane. There was a big infection, and the patient lost everything that was underneath that membrane. And now the implant that was placed has an peri-implantitis. And then she came to Brazil because she was not confident to treat this situation there in Argentina where she was. So she looked for a friend of mine, so a colleague of mine saw the patient, and he decided to take out the implant and the membrane. Okay? But please observe that this lateral incisor here is not in good shape. So the lateral incisor is definitely not a good shape. So when I saw those pictures, I told to my friend, my colleague, that he missed the opportunity of not of taking that tooth out in that moment. So anyways, he took out the two, the implant and the membrane, and he delivered for the patient a 4-unit bridge, but on top of this failing lateral incisor. Then I told him, listen, guy, this lateral incisor has to go. There's no way you can do anything here with this lateral incisor. Because remember, the magnitude of the bone regeneration is lined with the interproximal bone peaks. And here you can see that distal to this root, the bone peak is here in the apical direction. There is no way you can create bone here in this area. Therefore, we had to take the tooth out. We took the tooth out, the lateral incisor, okay? And we filled the area with LPRF plugs. And now the patient has a 5-unit bridge from the lateral here to the canine on the other side. Okay? So that is her current situation. We have to wait for the healing of the soft tissues. And here you can appreciate after 8 weeks, in which now the soft tissues are healed, and now you can appreciate the defect that we have here. It's a big defect in the anterior maxilla. Then, of course, it's the moment to do our GBR. So we open the flap, we cut here the incisal nerve, okay? And we remove all the content of that area. And in cases like that, I prefer to check the mobility of the flap prior to doing anything else. So I decided to see if I would be able to close the flap in the best way possible. Placed the tenting screw, decortication, the membrane was stabilized in the palatal aspect, and this is a mixture of autologous bone and the xenograft, and of course LPRF. And then we are folding the membrane towards the buccal and stabilizing that with screws. We cut the excess of the membranes, and then we protect the edges of the membranes with a resorbable membrane that I mentioned to you that I don't use that anymore today. But anyways, I love using LPRF to facilitate the healing of the soft tissue. This is the suture that I mentioned to you, which is the horizontal matrix suture, and then finish with interrupted sutures. So this is a very fast, let me say, edition of the surgery. Again, if you are together there, I'm going to be showing the videos in the full length to see all the details that are important. And of course, we have to check the patient. So I like to see my patients very regularly. So this is 3 days, 7 days, and 14 days after the surgery when we take out the suture material. And here we can appreciate that after 2 weeks. So everything was completely closed, no opening, very nice healing. So I was able to remove the the sutures in a good way. And this is the patient after 3 months. I know that the provisional restoration may not be as beautiful as we wanted, but anyways, my colleague that was working with me, as a matter of fact, I was working with him because it's his patient. Okay, so he delivered for the patient a provisional restoration, and everything is completely sealed. You can see that there's absolutely no keratinized tissue here in this area because of the distortion of the mucogingival line. And in the X-ray, 3 months after the surgery, you can appreciate that it seems that the height of the bone is leveled to the tenting screw. And all that defect is filled with the bone inside. Of course, that's only 3 months, and we have to wait. At 6 months' time, so 3 months following this picture here, the patient said, now I have to return to Argentina because I have my business there. Okay, you can go there, but first do or obtain a CBCT. And this is the CBCT of the patient of 6 months. Please observe that underneath the membrane, space is completely filled with new regenerated bone. That in 6 months, it's still immature, not good for the placement of the implant at this moment. We have to wait a little bit more. So in the vertical defect, we like to wait 9 months. But as I mentioned to you, the patient decided to go back to Argentina prior to those 9 months time, and I said, okay, go, everything is good. So the patient went back to Argentina this moment, 6 months after the surgery. And please observe, the bone is good. 1 week after this CBCT, she was already in Argentina, and the provisional restoration got loose. Then she went to a local dentist that placed, repositioned the provisional restoration. And then she called us just after that, saying that there was a problem. And she took a picture in the mirror of her car. And you can see here the pus coming out of her gingiva and a lot of inflammation here. Then we told her what happened. And she said, well, I went to the doctor and he repositioned, recemented the provisional restoration. But I felt, she said, that he pushed it too much. And then we said, listen, now there's an infection. Number one, you have to take antibiotics immediately. And number two, you have to go to another dentist to take out the provisional restoration and in position with some space. And this is the image of the patient just when she got to another dentist. You can appreciate here that the indentation of the internal part of the restoration that was inside the soft tissue. So the first dentist there, he pushed it too much in that area. So he created a problem for us here. And now the other dentist repositioned it better. So you can see how deep the other guy pushed up the prosthesis. Then we told her, listen, you have to keep using the antibiotics, but I would ask you to come back to Brazil as soon as you can. Because in my experience, whenever you have an infection like that, and we have a non-resorbable material underneath, it means that she probably going to lose everything. She was very, very in the she was very upset with that information. She was very how is the word that I'm looking here? In this despair, she was afraid of that. So she came back to Brazil immediately. And when she came back to Brazil, she came back with the CBCT. Now this X-ray here is like no more than 1 month after the other one X-ray. And in this time, you can already see that a lot of the bone is missing here. You can see that I'm losing the bone, and because of infection. And I know from my experience that if we don't reopen the site immediately, everything is going to be lost. So the patient must come back immediately to the office to do that. So she came from Argentina to Brazil, and this is the picture of the patient when I saw her in my office. It was a Saturday night when she came back. And you can appreciate there is a fistula here. And when I saw this X-ray, I didn't like what I saw because I felt a lot of empty spaces there. So that means resorption, that means infection. Then I said, okay, let's open to see what's going to happen. And then we have to reopen the site. And this is a very tense moment because when I reopen the membrane here, I'm going to see what's underneath. And this is what underneath. So a lot of infection. Now we have to take the membrane out. I take the tenting screw out and I start to scrape what is loose. And I scrape, I scrape, I scrape, and then I felt something good because here I could feel that internally, I lost everything in the center, but towards the the extremities, oops, towards the extremities there, the bone was good. So after I cleaned everything, I felt comfortable to do a relining. So this is a membrane. This is Krios, by the way, that I'm tacking in the palatal aspect. And this is the sticky bone. So xenograft and RPRF, just to fill the space in the center and do the relining on the regeneration area. Okay? This is the so-called sausage that we are creating here, covering with the LPRF membranes and the suture. This is the provisional restoration in position again. So this is like 2 weeks following the surgery. You can appreciate that now we have lost even more the vestibule depth in this area, but it seems to be healing well. Now we have to wait. And this is the patient after some months. We have to wait like here 6 months because of this new round of regeneration, but everything seems to be okay. So this is the CBCT of the patient. You can now see the original bone that was regenerated and the relining on top of that. And in the center, we're able to level everything up in a very nice way. So this is the treatment planning, the digital treatment planning, that we decided to place 2 implants with a 3-unit bridge. So this is it being prepared. And this is the surgery. And here I'm doing a sharp dissection. I don't want to do a full thickness flap in that area because I don't want to challenge the new regenerated bone. And after I do that, I just go and drill and place my implant. So this was completely guided, but this one here was drilled, and then we have to place the implant freehand because of the sleeve dimensions. The connective tissue graft was removed, and the connective tissue graft from the tuberosity was removed. And here we are placing the connective tissue graft on top of the healing aspect, and then the connective tissue graft from the tuberosity being also positioned in that area. If it was today, I would have placed this connective tissue here on top of this one. This connective tissue here is from the tuberosity. And remember that it has the potential to grow. So it should have been placed on top of the first connective tissue. Because now the connective tissue on top of that, which is this one here, will kind of block the potential of overgrowth of this connective tissue here. So ideally, I should have added the connective tissue on top of the other, like this, and suture. Professor Istvan Urban calls that the iceberg technique. Okay? And then, of course, we suture. And here you can see the suture and the provision restoration in place. And this is like a summary of the patient, how she started after here the removal of the implant and the membrane, after the regeneration, and after the implant placement. Please observe that the patient doesn't have any keratinized tissue. Therefore, now it's the final moment to finish the surgery in the best way possible. And here we have to recreate the vestibule depth and recreate a good band of keratinized tissue. Please observe that there is no keratinized tissue here. So we use the strip gingival graft concept. So this is the removal of a very narrow band or narrow dimension of a very long free gingival graft in a way that we are going to place that in the apical direction in the vestibule depth to block the alveolar mucosa to come back to its original position. So we love doing this kind of surgery. It's very clean. Most of the times, very easy to be performed. To take a free gingival graft like that, it's very fast, very easy. Less pain that we anticipate. So this is the first gingival graft that is for the apical direction. And then, of course, I'm going to take another free gingival graft for the cervical region on the collar, on the neck of our implants. So these are much more narrower in terms of the mesial-distal aspect, but more advanced in the apical coronal direction. So wider, but shorter free gingival graft. So one for the apical, one for the cervical region. And then we suture this area. How we protect this? We like to place a collagen sponge, and then we apply the sutures to help the stabilization of that collagen sponge in the area. So the name of the suture is Y suture, like letter Y suture. Okay? And then cyanoacrylate is going to be positioned on top of that. So a layer of cyanoacrylate is going to be layered over that area, and that will seal that area in a very good way. And this is the recipient site. So here we are creating the bed for the placement of the graft. And here we are stabilizing the alveolar mucosa in the apical direction. And this is the free gingival graft that we collected, and we are stabilizing that now distal and mesial. And then we anchored that graft with this kind of compression sutures anchored on the periosteum. And the other connective tissue, or the other free gingival graft was placed and stabilized in the cervical direction. And that is how the patient was finished. Here you can appreciate the two grafts in position and the prosthesis back to its area. So it heals very fast. As you can see here, this is maybe 1 week following the surgery. So we don't see anything exposed anymore. So the soft tissue grows really fast in that area. So we like to protect it and clean using laser. And this is after some more weeks in which you can appreciate that the palatal area is completely healed. And we are creating here a good band of keratinized tissue in the neck of that area. So the patient went back to Argentina again, stayed there for some months, and then when she returned, my colleague, so he removed the tenting posts, the tenting healing caps, and he placed, intermediate component here, and on top of that, a provisional restoration on top of that. So here you can appreciate how the patient is actually right now. So an excellent bed of keratinized tissue here in this area, a very decent height of the tissues. I would like to do like a crown lengthening here, but the patient doesn't like it. I still would like to have the opportunity to do one extra graft to bring the tissue in a more coronal direction to create here like a papilla, but the patient is so happy that she doesn't want to change anything. Okay, and you can see the stability of the bone here. And this is how the patient started, and this is how the patient looks like right now, and the stability of the bone interproximally. So, my dear friends, coming towards the closure of my presentation here. So I told you that everything matters, since from the incision to the suture. And if we do that, you can see here horizontal and vertical defects in the anterior maxilla, in the posterior maxilla, in the anterior mandible, in the posterior mandible, all cases very well restored in the best way possible with good bone formation in that area. So it's possible to recreate this new bone. Is it stable? Is it stable? Yes, it's stable. So here we can see a 12 years stable case. So we can see how we started with this very, very dramatic posterior mandible and how we were able to recreate the bone in the best way possible. And this is 12 years down the line. So very stable. This is my oldest case, the first vertical augmentation that I did in 2005. So right now it's 20 years. I forgot to replace this. 20 years follow up. It may not be perfect, but this is how I started with a dental gingival prosthesis. And this is now a patient looks like after 20 years of maintenance. And this patient comes to my office one time a year at least. So this shows pretty much that our outcomes are completely in line with some of the most prestigious researchers on the topic, claiming that if you use the right technique, the guided bone regeneration is a very reliable and predictable technique, yet sensitive. And the new regenerated bone responds as the native bone to the placement of implants. So it's not because it's a regenerated bone that's going to be lost through time. And this is what we can see in our cases here. So, take home message when it comes to this topic. It's a very sensitive procedure, but predictable, that requires multiple surgeries. So it's one miracle at a time. So patients like that has to do at least 3 surgeries, generally speaking, which is the bone augmentation, the implant placement, and the relining, and then the mucogingival part of the surgery in the end. Because of those surgeries, it requires a lot of time, a lot of cost, and the morbidity. So it's not easy for the patient to go through all that process. But if the patient is a good patient and understands the benefits of that, that's a great alternative for the dental gingival prosthesis. But it requires experience, and the learning curve is very big. It never ends. I myself, I think that I'm very experienced today. I have done countless cases for the last 20 years, and I'm still learning. There's a lot of tricks that when I see somebody doing something different, that well, that's a smart move. So let's incorporate that to our armamentarium. Okay? So thank you guys for being here. So I know that we might have some questions, but before that, before I pass the word to Michael and Beth, uh, let me do like this small advertising. So for all of you that enjoyed this short presentation, that is very challenging for me to do because I don't feel you. I don't have the opportunity to look to your faces. So it's a little bit awkward for me to talk to the computer. So maybe my performance here may not be as great as could have been if I was in person. But anyways, if you enjoyed the idea, we might be together on May 23rd to 25th in a way that I can show you much better the 3 pillars of the periimplantology and show you much better, much more, a lot of topics that shall be discussed. And that can be the beginning of a partnership in terms of clinical practice. So the guys or the colleagues that can enroll in that course, actually we want them to come to Brazil to do like this 1 week clinical practice course in a way that we can implement that clinically, what we have learned there with you. I'm going to be there 3 days specifically talking about all the decision trees that we use and much more in depth that I did here today. So that is message number one. Message number two, there is the ImplantePerio Play platform that if you want to be close to us, so this is the channel. So this is like a QR code that if you take a picture of this here, it's gonna lead you to the WhatsApp group of the ImplantePerio community. And every month, you're gonna receive a link of the live surgery and all the information regarding um, our activities. Yesterday night, I did a very big root coverage from molar to molar. So multiple gingival resection from molar to molar. Very long, very big procedure, but everybody could see in details. And for those who would like to participate more in depth in the ImplantePerio Play, you can pay like a fee, an annual fee, and you're gonna see more than 550 videos that you just saw here today, similar to the ones you saw here today, but much more complete cases. And the live surgeries will be there as well. So if you want to do the live surgery again, not like a live, but you can see whatever you want. That's number two. And number three, or I mean, this is our ImplantePerio platform, okay, which is now in Portuguese, but we are changing that to English. And here you can have the live activities, okay, and you have the recorded activities here as well. So it's more than 550 materials here. So this is, for instance, the live surgery I did last month. This yesterday I did another live surgery. So amazing, this platform. And last but not least, for those who want to be in our International Congress of ImplantePerio, this is the sixth edition. So this edition number six is going to be on September 10 to 12 this year. Okay. And those five international speakers speaking together for the first time in Brazil in longer, little bit longer lecture, like 4 hours lecture to fulfill, to expose as much as they can show. So please also be with us for those who can be
Mhm.
with us. So we are expecting like 500 participants, and we now are getting to the 400 subscription. So only 100 seats available, but the Congress is going to be on September. So we are pretty sure that by next month, all the tickets will be sold out, and we are extremely happy because of that. A private meeting made by three guys, which is myself, Jolie, and Paulo, without the sponsorship, like many other big meetings. So people come to our meeting because they rely on the decision trees that we perform over the 20 years plus working together. And that means a lot to us. And that is it, Michael and Beth. I know that you may have some questions, and now is the moment to answer them and right on time.
Can I just thank you, by the way, Robert? Like it's awesome what you're proposing and showing us and all that good stuff. I just have a question about the symposium. Can you just comment on who those five people are and if it's going to be in English or not?
Yes, it's going to be in English for sure. So we're going to have uh, the translation in English, okay? And I'm going to show you here the just a second. Implant pair play.
Because I did see different flags, French flags and Spanish flags, and
Huh?
so I assume they're different
So
countries.
Yes. I'm going to show you here. Here. And by the way, if you had the opportunity to enroll in our WhatsApp group this month, we're gonna have the
Okay.
lecture live of Dr. Maria Elisa Galarraga from United States, okay? But Vincent Ronco, Serbat Aslan, and this guy here, this Vincent Ronco here, is amazing guy with soft tissue management. So he's like one master in root coverage. How we're gonna learn a lot of tricks regarding suture. He has his own way of suturing that which is very amazing. Okay, Dr. Aslan here is one of the guys who perform periodontal regeneration using the so-called entire papilla flap creation in which he access the defect in a beautiful way without cutting the papilla. So a very unique way of achieving access or getting access to the defect, but without destroying the papilla underneath the defect. Dr. Maria Elisa Galarga, she's unbelievable with peri-implant tissues as well. So she's going to show us a lot of tricks regarding peri-implant stability and reconstruction. Dr. Ernest Luca, so he's unbelievable in aesthetics as well. And this guy here is a monster. So Dr. Juan Zufia from Spain, he is unbelievable in terms of reconstruction. So one of those guys that are so good in what they do because it's unbelievable the technique and the skills this guy has and everybody here as I mentioned to you, and this is the first time they'll be together in Brazil and providing these long lectures. Dr. Vincent Ronco as well is going to do like a pre-event. So we're going to have like a pre-event in which he's going to demonstrate, in big jaws and models how to perform, his sutures. And that's something very nice that people like to practice because what one thing is seeing that, other thing is doing that. So he's going to demonstrate that. So this is our homepage of the sixth International ImplantePerio Congress. It's going to be in English and in Spanish. So it's simultaneous translation, Portuguese, Spanish, and English.
That's awesome. And I like the date because it's Sao Paulo, which is very close to where we're going to be for our cohort, which is September 15 to 20. So this is the weekend just before we're there. So, you piqued I know what that's thinking. I guess we're going to be going a little bit early and maybe do a little symposium before we do a little bit of meeting together. So I hope that many people on this call can join us and then we can have even a
Okay?
little bit more fun and we'll have a little break in between that we can enjoy the Brazilian hospitality.
Yes, yeah, which is very good.
Yeah,
But
maybe we'll bring some lobsters and we can have some, Brazilian steaks as well.
and
Do a little
some
surf and turf.
paçoquinhas. I'm
Yeah,
going to bring some paçoquinhas.
yeah, excellent. Okay, go ahead,
So,
Beth.
so we do have a few questions in the chat if you don't mind.
Yeah, no problem.
Okay, so the first one is between the two techniques, Corey technique with block graft versus GBR membranes, what is the difference with bone loss to remodeling?
Uh, you know, if you look at the literature of both, you're gonna see that those who are performing the Curie technique, they claim that is much better. Those who like the GBR are gonna claim that GBR is much better. And it's very difficult to compare because you cannot match the clinical cases exactly to the one side versus the other side. But in reality, there are advantages and disadvantages of both techniques. So if you think about the Curie technique, so if I do the Curie technique today, in 3 to 4 months later, I can place my implants. So much faster because GBR is 6 months to 9 months waiting time. So much faster. Secondly, when you do the Curie technique, if you have a complication, generally speaking, it's easier to manage because if you have an exposure of a bone block, you can kind of trim that area to cut that area with a burr, and then you can try to suture that area and clean, of course, that area. If you have an exposure of the membrane, it's much more challenging to clean. So basically, we have to open and remove everything most of the case because if you let the infection take control, you're going to lose everything. So it's much more difficult to control. In terms of cost for the practitioner, for us, if I'm going to do a Curie technique, it's much cheaper for me to perform it because to do a Curie, what I need is only the screws, the specific screws. If I think about doing the GBR, it's much more expensive because I have to use the membrane, I have to use the tenting screw, I have to use the tacks or the screws to stabilize the membrane. I have to use the biomaterial to uh, to mix with the autologous bone. So it's much more expensive. However, in terms of predictability, it's the same. So both will work well in the good indications. Okay? Uh, Another situation is the morbidity. So, in my opinion, this is my opinion. Now, I think that GBR is much less painful for the patient. So, thinking about taking some bone shavings as opposed to take a big block. So, it's much more demanding for the patient and much more difficult to place the tacks, to place the block, the blades of the bone, and to create the box. So Michael could see that in sight. So he could see in Paulo's office how hard it is to stabilize the blocks, the blades, and much more easier to stabilize the membrane on top of the defect. So in my perspective, GBR is easier and less painful for the patient, but much more time consuming in terms of the length of the treatment, and the cost of it is much higher for us. Okay, but in terms of predictability, is the same. So the stability of the regenerated bone should be the same as well. And so that is very hard to say. But if you look at the literature, it's biased, in my opinion, because those who like uh, GBR will tend to tell good things about GBR. Those who like Curie will tend to, show the benefits of that technique. But in my perspective, because I do GBR a lot, and Paulo, my partner, he loves doing the Curie, and we have similar outcomes.
Just a question on Curie though. If if you live in a country that can have allograft blocks, do you have any opinion on there or any experience with allograft? Because then you don't have the morbidity of the host site, but you have an increased cost of the block. But I don't know if you can comment on that one.
Yeah, I personally don't have any experience with that, okay? But I know that Paulo has tried. But I would say that yes, you reduce the morbidity related to the bone blocks, but it seems that you have a higher rate of complications
Okay.
related to that because there's more tendency to perforate the flap, and because it's allograft material, it doesn't behave like the bone of the patient when it has a problem. But again, I cannot comment too much or further than that because it's not my stuff.
Okay. No, thank you.
So we have another question. What's the name and brand of the resorbable membrane that you like to use for horizontal defects?
Krios Xenoprotect from Nobel Biocare. For me, one of the best membranes ever.
Okay. Another one, is it really possible to release buccal and lingual flaps up to 30 millimeters using periosteal release with brushing technique on buccal and superficial muscle release on lingual? By Dr. Rhonda and Stacy.
Yes, it is. pretty much possible, but it's technically sensitive, and we must learn the tricks to know how to stretch the tissues with this periosteal releasing in the buccal area and the lingual with the mylohyoid muscle. So there are different techniques to do that, but it's possible. It's really possible, and we must know how to do that if you are going to do GBR or bone augmentation procedures, because if you can't, you know, release the tissue in a way that you can cover everything and invert the flap like this, connective tissue against connective tissue, never finish like that, okay? Because this means opening. If you can do like that with the release of the tension, you're gonna be just fine.
With the second round of regeneration, was there no decortication?
Yes, yes, no decortication because let me say that the second round of regeneration, the bone was still immature, so there are like spaces for the revascularization or the cellular communication in that area. So I don't think it's required the decortication on the second round um, GBR or the relining GBR. The objective is only creating the stability of that and maybe some volume, extra volume to that area.
Okay, and one last question. Please share what tacking instrument you're using now instead of screws for membrane fixation.
Oh,
Secret weapon.
that's a that's a secret weapon.
Yeah.
I will show you only for those who are present in the event. Okay, so when I'll be there, I'll be showing that that's a kind of secret. That's really.
Just so happen I have that secret in my, in my office. You have to go to Brazil to get it.
Had to go to Brazil or be with us in a couple of months.
Correct. Correct.
Thank you. Lots of great, compliments in the chat. Lots of thank yous. Excellent presentation. Mind-boggling surgical techniques and skills. So good job. Thank you.
Thank you very much for the opportunity. I hope you have enjoyed. Again, apologies for the way it was, done here. I feel a little bit awkward talking to the computer. So Michael knows me already, like in real life. It's much better. So I hope I have given you a good impression, first impression for all of you, but I hope I have another chance to be with you in person, and that
Oh,
might be even better.
absolutely. I can't wait for May. Just a little bit of housekeeping. I will also, I think I have everybody's cells and emails and stuff that are on this call. So what I will try to do, the people that are not already on WhatsApp, either WhatsApp like IP Canada or IP Brazil, I can put you in those WhatsApps. That's some of the stuff that I will do. And if you don't want to be part of it, you can just unsubscribe or whatever. But the other thing that I want to do is just a final thank you to our sponsors, Nobel Biocare, Dental Corp, High Tech Medical Instruments, and the one that we haven't seen yet on our little flyer is Hallmark Lab. So this is as of today. So now Hallmark's going to be with us and they will be there in May. So all these people will be there in May. We'll get together, have lots of fun. We'll have, I think we have 2 suppers together as well. So we'll have, oh, the other thing before I forget, for that course, we will also have a bonus on the Thursday evening. So that will be on May 22nd in coordination with the Atlantic Implant Study Club. So basically Marco's study club at Citadel, which is the same place we're having the course. So we will have a 2-hour, basically 2-hour study club meeting, which will be hosted, I guess, by Robert's. I'll call Robert Batman and I'll call Virgilio Robin. So he is excellent. If you guys went to the American Equilibration Society meeting this year, you would have seen the best presentation in the Congress, which was Virgilio. So he will do a session on osteodensification and also Crestal sinus lifts using the VersaBurs. So that'll be an added plus for anybody who's doing the course. You will also be part of that study club. And again, we'll have a little bit of food there. And then we'll have 3 days of education, a couple nights together. Should be a blast. Can't wait. With that, I think that's everything.
Very good. Thank you, guys.
Thank you very much, everybody. Hope to see you all in May. All right, register soon. Thanks. And then in Brazil.
Bye-bye. Thank you.
Bye-bye.
Thank you, everyone.
Thanks, Robert.
Bye-bye.
See you soon.
Thank you.